is increasingly recognized as a hub for education and intellectual growth. Among its leading educational institutions is Mahasaraswati University, which operates under the management of Community Education Foundation of Saraswati Pusat Denpasar, a foundation that has been committed to education since December 8, 1946. Mahasaraswati University is home to 8 distinguished faculties, including the Faculty of Pharmacy, which holds a unique and storied legacy. This faculty traces its roots back to the establishment of the Pharmaceutical Assistant Academy on February 1, 1969, a pioneering initiative that became the first and only pharmacy school in eastern Indonesia at that time. This academy laid the foundation for what is now the Faculty of Pharmacy, a faculty that blends academic excellence with cultural and technological innovation. The Faculty of Pharmacy is driven by a clear and ambitious vision: to become an excellent, innovative, and cultured faculty. Excellence signifies a commitment to the highest academic and professional standards, while innovation emphasizes the utilization of cutting-edge technology to deliver patient-centered pharmaceutical care and conduct impactful research that contributes to global knowledge. Cultured reflects the integration of traditional values and local wisdom, empowering graduates to explore the potential of traditional medicines as alternative and complementary care options for the community. The faculty offers 2 highly regarded study programs, the Bachelor of Pharmacy and the Diploma in Pharmacy. Both programs have achieved excellent accreditation, underscoring their role as leaders in pharmaceutical education in Bali. These programs are designed not only to prepare students as pharmaceutical professionals but also to nurture entrepreneurial skills, enabling graduates to thrive in roles such as medical representatives, herbal medicine developers, and leaders in the traditional medicine industry. Recognizing Bali's prominence as a global tourist destination, students also receive comprehensive training in communication, interpersonal skills, foreign languages, and cultural studies, equipping them to excel in diverse and multicultural settings. The faculty boasts an impressive array of achievements, including gold medals at international competitions and numerous research projects funded by the government. These accomplishments reflect the dedication of both students and lecturers to advancing pharmaceutical sciences. To support its mission, the Faculty of Pharmacy continuously enhances its infrastructure and human resources. It operates within 2 modern 4-story buildings, equipped with state-of-the-art laboratories, lecture halls, and advanced technological resources. These facilities provide an ideal environment for learning, research, and innovation, cementing the faculty's reputation as a leader in pharmaceutical education in Bali. Students benefit from high-quality instruction delivered by lecturers with exceptional academic and professional credentials. The faculty also offers access to free campus-wide Wi-Fi, a vast library collection, and partnerships with pharmacies, hospitals, and other healthcare institutions across Bali, ensuring ample internship opportunities to develop practical skills. Beyond academic pursuits, the Faculty of Pharmacy is deeply committed to community service. These initiatives often focus on applying cutting-edge research with cultural sensitivity, such as educating communities about the benefits of herbal plants for traditional medicine, drawing on principles from Ayurveda and local wisdom. Such efforts reflect the faculty's mission to blend science with tradition, enriching the lives of those it serves while preserving Bali's cultural heritage. The institution also proudly operates Apotek Saraswati Medika, an education-focused pharmacy store designed to enhance student learning. This innovative facility serves as a hands-on training ground where students can apply their knowledge in a real-world setting. Apotek Saraswati Medika reflects the faculty's commitment to integrating education with practical experience, preparing graduates to excel in the pharmaceutical care and management. The Faculty of Pharmacy at Mahasaraswati University is more than an academic institution, it's a vibrant hub of innovation, tradition, and community impact. Combining rigorous academics with cultural wisdom, it prepares graduates to excel as skilled professionals and leaders in the dynamic world of healthcare. By blending modern pharmaceutical science with traditional medicine, the faculty offers a unique approach that preserves Bali's heritage while addressing global healthcare challenges. Through advanced facilities, impactful research, and strong community engagement, the faculty empowers students to make meaningful contributions locally and internationally. Joining the Faculty of Pharmacy means becoming part of a transformative journey, where science meets tradition and education drives real-world change. The island of Bali is widely celebrated for its breathtaking beauty as a world-renowned international tourism destination. Beyond its reputation as a haven for vacationers, Bali is increasingly recognized as a hub for education and intellectual growth. Among its leading educational institutions is Mahasaraswati University, which operates under the management of Community Education Foundation of Saraswati Pusat Denpasar, a foundation that has been committed to education since December 8, 1946. Mahasaraswati University is home to 8 distinguished faculties, including the Faculty of Pharmacy, which holds a unique and storied legacy. This faculty traces its roots back to the establishment of the Pharmaceutical Assistant Academy on February 1, 1969. A pioneering initiative that became the first and only pharmacy school in eastern Indonesia at that time. This academy laid the foundation for what is now the Faculty of Pharmacy, a faculty that blends academic excellence with cultural and technological innovation. The Faculty of Pharmacy is driven by a clear and ambitious vision: to become an excellent, innovative, and cultured faculty. Excellence signifies a commitment to the highest academic and professional standards, while innovation emphasizes the utilization of cutting-edge technology to deliver patient-centered pharmaceutical care and conduct impactful research that contributes to global knowledge. Cultured reflects the integration of traditional values and local wisdom, empowering graduates to explore the potential of traditional medicines as alternative and complementary care options for the community. The faculty offers 2 highly regarded study programs, the Bachelor of Pharmacy and the Diploma in Pharmacy. Both programs have achieved excellent accreditation, underscoring their role as leaders in pharmaceutical education in Bali. These programs are designed not only to prepare students as pharmaceutical professionals but also to nurture entrepreneurial skills, enabling graduates to thrive in roles such as medical representatives, herbal medicine developers, and leaders in the traditional medicine industry. Recognizing Bali's prominence as a global tourist destination, students also receive comprehensive training in communication, interpersonal skills, foreign languages, and cultural studies, equipping them to excel in diverse and multicultural settings. The faculty boasts an impressive array of achievements, including gold medals at international competitions and numerous research projects funded by the government. These accomplishments reflect the dedication of both students and lecturers to advancing pharmaceutical sciences. To support its mission, the Faculty of Pharmacy continuously enhances its infrastructure and human resources. It operates within 2 modern 4-story buildings, equipped with state-of-the-art laboratories, lecture halls, and advanced technological resources. These facilities provide an ideal environment for learning, research, and innovation, cementing the faculty's reputation as a leader in pharmaceutical education in Bali. Students benefit from high-quality instruction delivered by lecturers with exceptional academic and professional credentials. The faculty also offers access to free campus-wide Wi-Fi, a vast library collection, and partnerships with pharmacies, hospitals, and other healthcare institutions across Bali, ensuring ample internship opportunities to develop practical skills. Beyond academic pursuits, the Faculty of Pharmacy is deeply committed to community service. These initiatives often focus on applying cutting-edge research with cultural sensitivity, such as educating communities about the benefits of herbal plants for traditional medicine, drawing on principles from Ayurveda and local wisdom. Such efforts reflect the faculty's mission to blend science with tradition, enriching the lives of those it serves while preserving Bali's cultural heritage. The institution also proudly operates Apotek Saraswati Medika, an education-focused pharmacy store designed to enhance student learning. This innovative facility serves as a hands-on training ground where students can apply their knowledge in a real-world setting. Apotek Saraswati Medika reflects the faculty's commitment to integrating education with practical experience, preparing graduates to excel in the pharmaceutical care and management. The Faculty of Pharmacy at Mahasaraswati University is more than an academic institution. It's a vibrant hub of innovation, tradition, and community impact. Combining rigorous academics with cultural wisdom, it prepares graduates to excel as skilled professionals and leaders in the dynamic world of healthcare. By blending modern pharmaceutical science with traditional medicine, the faculty offers a unique approach that preserves Bali's heritage while addressing global healthcare challenges. Through advanced facilities, impactful research, and strong community engagement, the faculty empowers students to make meaningful contributions locally and internationally. Joining the Faculty of Pharmacy means becoming part of a transformative journey, where science meets tradition and education drives real-world change. The island of Bali is widely celebrated for its breathtaking beauty as a world-renowned international tourism destination. Beyond its reputation as a haven for vacationers, Bali is increasingly recognized as a hub for education and intellectual growth. Among its leading educational institutions is Mahasaraswati University, which operates under the management of Community Education Foundation of Saraswati Pusat Denpasar, a foundation that has been committed to education since December 8, 1946. Mahasaraswati University is home to 8 distinguished faculties, including the Faculty of Pharmacy, which holds a unique and storied legacy. This faculty traces its roots back to the establishment of the Pharmaceutical Assistant Academy on February 1, 1969. A pioneering initiative that became the first and only pharmacy school in eastern Indonesia at that time. This academy laid the foundation for what is now the Faculty of Pharmacy, a faculty that blends academic excellence with cultural and technological innovation. The Faculty of Pharmacy is driven by a clear and ambitious vision: to become an excellent, innovative, and cultured faculty. Excellence signifies a commitment to the highest academic and professional standards, while innovation emphasizes the utilization of cutting-edge technology to deliver patient-centered pharmaceutical care and conduct impactful research that contributes to global knowledge. Cultured reflects the integration of traditional values and local wisdom, empowering graduates to explore the potential of traditional medicines as alternative and complementary care options for the community. The faculty offers 2 highly regarded study programs, the Bachelor of Pharmacy and the Diploma in Pharmacy. Both programs have achieved excellent accreditation, underscoring their role as leaders in pharmaceutical education in Bali. These programs are designed not only to prepare students as pharmaceutical professionals but also to nurture entrepreneurial skills, enabling graduates to thrive in roles such as medical representatives, herbal medicine developers, and leaders in the traditional medicine industry. Recognizing Bali's prominence as a global tourist destination, students also receive comprehensive training in communication, interpersonal skills, foreign languages, and cultural studies, equipping them to excel in diverse and multicultural settings. The faculty boasts an impressive array of achievements, including gold medals at international competitions and numerous research projects funded by the government. These accomplishments reflect the dedication of both students and lecturers to advancing pharmaceutical sciences. To support its mission, the Faculty of Pharmacy continuously enhances its infrastructure and human resources. It operates within 2 modern 4-story buildings, equipped with state-of-the-art laboratories, lecture halls, and advanced technological resources. These facilities provide an ideal environment for learning, research, and innovation, cementing the faculty's reputation as a leader in pharmaceutical education in Bali. Students benefit from high-quality instruction delivered by lecturers with exceptional academic and professional credentials. The faculty also offers access to free campus-wide Wi-Fi, a vast library collection, and partnerships with pharmacies, hospitals, and other healthcare institutions across Bali, ensuring ample internship opportunities to develop practical skills. Beyond academic pursuits, the Faculty of Pharmacy is deeply committed to community service. These initiatives often focus on applying cutting-edge research with cultural sensitivity, such as educating communities about the benefits of herbal plants for traditional medicine, drawing on principles from Ayurveda and local wisdom. Such efforts reflect the faculty's mission to blend science with tradition, enriching the lives of those it serves while preserving Bali's cultural heritage. The institution also proudly operates Apotek Saraswati Medika, an education-focused pharmacy store designed to enhance student learning. This innovative facility serves as a hands-on training ground where students can apply their knowledge in a real-world setting. Apotek Saraswati Medika reflects the faculty's commitment to integrating education with practical experience, preparing graduates to excel in the pharmaceutical care and management. The Faculty of Pharmacy at Mahasaraswati University is more than an academic institution. It's a vibrant hub of innovation, tradition, and community impact. Combining rigorous academics with cultural wisdom, it prepares graduates to excel as skilled professionals and leaders in the dynamic world of healthcare. By blending modern pharmaceutical science with traditional medicine, the faculty offers a unique approach that preserves Bali's heritage while addressing global healthcare challenges. Through advanced facilities, impactful research, and strong community engagement, the faculty empowers students to make meaningful contributions locally and internationally. Joining the Faculty of Pharmacy means becoming part of a transformative journey, where science meets tradition and education drives real-world change. The island of Bali is widely celebrated for its breathtaking beauty as a world-renowned international tourism destination. Beyond its reputation as a haven for vacationers, Bali is increasingly recognized as a hub for education and intellectual growth. Among its leading educational institutions is Mahasaraswati University, which operates under the management of Community Education Foundation of Saraswati Pusat Denpasar, a foundation that has been committed to education since December 8, 1946. Mahasaraswati University is home to 8 distinguished faculties, including the Faculty of Pharmacy, which holds a unique and storied legacy. This faculty traces its roots back to the establishment of the Pharmaceutical Assistant Academy on February 1, 1969, a pioneering initiative that became the first and only pharmacy school in eastern Indonesia at that time. This academy laid the foundation for what is now the Faculty of Pharmacy, a faculty that blends academic excellence with cultural and technological innovation. The Faculty of Pharmacy is driven by a clear and ambitious vision: to become an excellent, innovative, and cultured faculty. Excellence signifies a commitment to the highest academic and professional standards, while innovation emphasizes the utilization of cutting-edge technology to deliver patient-centered pharmaceutical care and conduct impactful research that contributes to global knowledge. Cultured reflects the integration of traditional values and local wisdom, empowering graduates to explore the potential of traditional medicines as alternative and complementary care options for the community. The faculty offers two highly regarded study programs, the Bachelor of Pharmacy and the Diploma in Pharmacy. Both programs have achieved excellent accreditation, underscoring their role as leaders in pharmaceutical education in Bali. These programs are designed not only to prepare students as pharmaceutical professionals but also to nurture entrepreneurial skills, enabling graduates to thrive in roles such as medical representatives, herbal medicine developers, and leaders in the traditional medicine industry. Recognizing Bali's prominence as a global tourist destination, students also receive comprehensive training in communication, interpersonal skills, foreign languages, and cultural studies, equipping them to excel in diverse and multicultural settings. The faculty boasts an impressive array of achievements, including gold medals at international competitions and numerous research projects funded by the government. These accomplishments reflect the dedication of both students and lecturers to advancing pharmaceutical sciences. To support its mission, the Faculty of Pharmacy continuously enhances its infrastructure and human resources. It operates within two modern four-story buildings, equipped with state-of-the-art laboratories, lecture halls, and advanced technological resources. These facilities provide an ideal environment for learning, research, and innovation, cementing the faculty's reputation as a leader in pharmaceutical education in Bali. Students benefit from high-quality instruction delivered by lecturers with exceptional academic and professional credentials. The faculty also offers access to free campus-wide Wi-Fi, a vast library collection, and partnerships with pharmacies, hospitals, and other healthcare institutions across Bali, ensuring ample internship opportunities to develop practical skills. Beyond academic pursuits, the Faculty of Pharmacy is deeply committed to community service. These initiatives often focus on applying cutting-edge research with cultural sensitivity, such as educating communities about the benefits of herbal plants for traditional medicine, drawing on principles from Ayurveda and local wisdom. Such efforts reflect the faculty's mission to blend science with tradition, enriching the lives of those it serves while preserving Bali's cultural heritage. The institution also proudly operates Apotek Saraswati Medika, an education-focused pharmacy store designed to enhance student learning. This innovative facility serves as a hands-on training ground, where students can apply their knowledge in a real-world setting. Apotek Saraswati Medika reflects the faculty's commitment to integrating education with practical experience, preparing graduates to excel in the pharmaceutical care and management. The Faculty of Pharmacy at Mahasaraswati University is more than an academic institution. It's a vibrant hub of innovation, tradition, and community impact. Combining rigorous academics with cultural wisdom, it prepares graduates to excel as skilled professionals and leaders in the dynamic world of healthcare. By blending modern pharmaceutical science with traditional medicine, the faculty offers a unique approach that preserves Bali's heritage while addressing global healthcare challenges. Through advanced facilities, impactful research, and strong community engagement, the faculty empowers students to make meaningful contributions locally and internationally. Joining the Faculty of Pharmacy means becoming part of a transformative journey, where science meets tradition and education drives real-world change. The island of Bali is widely celebrated for its breathtaking beauty as a world-renowned international tourism destination. Beyond its reputation as a haven for vacationers, Bali is increasingly recognized as a hub for education and intellectual growth. Among its leading educational institutions is Mahasaraswati University, which operates under the management of Community Education Foundation of Saraswati Pusat Denpasar, a foundation that has been committed to education since December 8, 1946. Mahasaraswati University is home to 8 distinguished faculties, including the Faculty of Pharmacy, which holds a unique and storied legacy. This faculty traces its roots back to the establishment of the Pharmaceutical Assistant Academy on February 1, 1969, a pioneering initiative that became the first and only pharmacy school in eastern Indonesia at that time. This academy laid the foundation for what is now the Faculty of Pharmacy, a faculty that blends academic excellence with cultural and technological innovation. The Faculty of Pharmacy is driven by a clear and ambitious vision to become an excellent, innovative, and cultured faculty. Excellence signifies a commitment to the highest academic and professional standards, while innovation emphasizes the utilization of cutting-edge technology to deliver patient-centered pharmaceutical care and conduct impactful research that contributes to global knowledge. Cultured reflects the integration of traditional values and local wisdom, empowering graduates to explore the potential of traditional medicines as alternative and complementary care options for the community. The faculty offers 2 highly regarded study programs, the Bachelor of Pharmacy and the Diploma in Pharmacy. Both programs have achieved excellent accreditation, underscoring their role as leaders in pharmaceutical education in Bali. These programs are designed not only to prepare students as pharmaceutical professionals but also to nurture entrepreneurial skills, enabling graduates to thrive in roles such as medical representatives, herbal medicine developers, and leaders in the traditional medicine industry. Recognizing Bali's prominence as a global tourist destination, students also receive comprehensive training in communication, interpersonal skills, foreign languages, and cultural studies, equipping them to excel in diverse and multicultural settings. The faculty boasts an impressive array of achievements, including gold medals at international competitions and numerous research projects funded by the government. These accomplishments reflect the dedication of both students and lecturers to advancing pharmaceutical sciences. To support its mission, the Faculty of Pharmacy continuously enhances its infrastructure and human resources. It operates within 2 modern 4-story buildings, equipped with state-of-the-art laboratories, lecture halls, and advanced technological resources. These facilities provide an ideal environment for learning, research, and innovation, cementing the faculty's reputation as a leader in pharmaceutical education in Bali. Students benefit from high-quality instruction delivered by lecturers with exceptional academic and professional credentials. The faculty also offers access to free campus-wide Wi-Fi, a vast library collection, and partnerships with pharmacies, hospitals, and other healthcare institutions across Bali, ensuring ample internship opportunities to develop practical skills. Beyond academic pursuits, the Faculty of Pharmacy is deeply committed to community service. These initiatives often focus on applying cutting-edge research with cultural sensitivity, such as educating communities about the benefits of herbal plants for traditional medicine, drawing on principles from Ayurveda and local wisdom. Such efforts reflect the faculty's mission to blend science with tradition, enriching the lives of those it serves while preserving Bali's cultural heritage. The institution also proudly operates Apotek.
Good morning, distinguished guests, respected speakers, esteemed colleagues, and all participants. Om Swastiastu. Assalamualaikum warahmatullahi wabarakatuh. Shalom, Namo Buddhaya, salam kebajikan, and warm greetings of virtue. It is my great honor to welcome you all to this international seminar on patient-centered care in clinical and community pharmacy, organized by the Faculty of Farmasi, Universitas Mahasaraswati Denpasar, here in Bali, Indonesia. Today's seminar brings together professionals and academics who share the commitment to improving patient-centered practices in pharmacy. May today's sessions inspire meaningful dialogue and fruitful collaboration across countries. Allow me to introduce myself. My name is Sadera, and I will serve as your Master of Ceremony. On behalf of the organizing committee, I would also like to extend a warm welcome and deep appreciation to the Honorable Rector of Universitas Saraswati Denpasar, Dr. Made Sukamerta MPD, or his representatives, along with the vice rectors. The Dean of the Faculty of Farmasi, Dr. Apotek Ketut Agus Adianta S.Farm and Biomed, and our esteemed speakers today, Dr. Apoteker Yunita Nita, SSI M.Farm, Dr. Wong Yuetian, and Professor Dr. Sayyid Azhar Said Sulaiman, and all distinguished participants joining us both on-site and online. Your presence is a great honor and enriches the significance of this event. Ladies and gentlemen, to open this seminar with a cultural welcome, let us enjoy the performance of Tari Pendet, a Balinese traditional dance symbolizing gratitude and hospitality. Ladies and gentlemen, please enjoy Tari Pendet.
you to our dancer for this beautiful and meaningful performance. Okay, before we continue, let us seek
blessing for the smooth progress of today's event by offering a prayer according to our individual beliefs. Ladies and gentlemen, I kindly invite you to stand.
Let us pray together. Thank you. Please remain standing. We will now sing the Indonesia National Anthem, Indonesia Raya. The conductor is invited to the podium. Thank you. Please be seated. To begin this seminar formally, we are honored to invite the Dean of the Faculty of Farmasi, Universitas Mahasaraswati Denpasar, to deliver the welcoming remark. The Honorable Dr. Apoteker Ketut Agus Adrianta, S.Pharm and Biomed, the floor is yours.
Good morning, distinguished guests, esteemed colleagues, respected speakers, and all seminar participants. Om Swastiastu. Assalamualaikum warahmatullahi wabarakatuh. Salam sejahtera untuk kita semua. Shalom, Namo Buddhaya. First and foremost, I would like to extend my warm welcome to the Honorable Rector of Universitas Mahasaraswati Denpasar, Dr. Andes Imade Sukamata MPD, along with the Vice Rectors, the Vice Deans of Fakulty of Farmasi, the Head of Diploma and Bachelor of Pharmacy Study Programs, Head of Department, Lecturer, Staff, and all students of Fakulty of Farmasi, Unmas Denpasar, representative of the Indonesian Pharmacists Association Bali Region, and especially our esteemed speakers, Dr. Apoteker Nita M.Pharm from Universitas Surabaya, Dr. Wong Yulian from Fakultas Farmasi, University Teknologi Malaysia, Professor Dr. Syed Asar Syed Sulaiman from School of Pharmaceutical Science, University Science Malaysia. We are deeply honored by your presence here today. Welcome to Bali. Welcome to Fakultas Farmasi, Universitas Mahasaraswati Denpasar, Bali. With sincere gratitude to Ida Sang Yang Widiwasa, God Almighty, we are blessed to gather here for the important event, International Seminar on Patient-Centered Care in Clinical and Community Pharmacy. With the topic, Implementation of Patient-Centered Care in Information Gathering and Organization based on the patient-level needs, problem and solution in pharmacy practice across countries. Ladies and gentlemen, this seminar provides a valuable opportunity to reflect on the critical role of patient-centered care in both clinical and community pharmacy. Today, we will gain insight for international experts who will share their knowledge and experience and how to effectively implement this approach in various healthcare systems. I would like to express my heartfelt appreciation to all our distinguished speakers for their willingness to contribute to this seminar. I would also like to thank more than 500 participants, both attending in person and online, who have joined us to make this event a success. It is our hope that this seminar not only broadens our perspective, but also inspire to continually improve the quality of patient care in our pharmaceutical practice. Let us make the most of this valuable opportunity to exchange ideas, learn from one to another, and strengthen our professional networks. Thank you for your kind attention. May this seminar proceed smoothly and successfully. Now, I respectfully invite the Honorable Vice Rector of Universitas Mahasaraswati Denpasar, Dr. Ikoman Budiarta, SPD MPD, to deliver his address and officially open the event. Om Santi 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 Om. Wassalamualaikum warahmatullahi wabarakatuh. Salam sejahtera untuk kita semua. Sadu sadu sadu. Salam kebajikan.
Officially open today's seminar, we are honored to invite the Rector of Universitas Mahasaraswati Denpasar to deliver the opening
remarks. On this occasion, the Honorable Rector is represented by the Vice Rector of Research, Innovation and Corporation, the Honorable Dr. Ikoman Budiarta, SPD MHUM MPD. The floor is yours.
Om Swastiastu. Assalamualaikum warahmatullahi wabarakatuh. Salam sejahtera bagi kita semua. Namo Buddhaya, salam kebajikan, rahayu rahayu rahayu. Good morning, ladies and gentlemen. First of all, I would like to send our best regard from the rectors. Actually, he would like to attend this very wonderful meeting. However, because of very important duty, he assigned me to attend this international seminar. First of all, I would like to address our excellent, outstanding speakers today. We have two colleagues from Malaysia, Professor Dr. Syed Asar Syed Sulaiman from University Science Malaysia. Thank you, Professor. And we also have Dr. Yuan from University Teknologi Malaysia.
Thank you once again. We have so many collaborations with UITM and our Indonesian partners, Dr. Nita from Universitas Erlangga University. Our colleges, Vice Rector the Dean of Faculty of Pharmacies and all staff, our beloved students and distinguishing participants who attend these international seminars. First of all, I would like to say that a very good congratulations to Faculty of Pharmacy, who is holding these wonderful international seminars on patient-centered care in clinical and community pharmacy. Thank you very much. And I do hope that this seminar will bring fruitful impact for our institutions, particularly Faculty of Pharmacies, and all distinguishing participants, both who are here on site and who also attend this conference or seminars online. And we do hope that the networking between our university and our colleges from Malaysia, from USM, from UITM, from UNER also, could keep going on, holding new events which might benefit to institutions between our institution and also your institutions. For your information also, Unmas Denpasar is one of the private university in Bali. We are under the LL Dikti, or Institutional Agencies Region 8, and we are quite big private university, and that is why as a private university we try to keep our innovations to survive in the future competitions of higher educations. In Faculty of Pharmacies, we have now 2 programs, diploma and bachelor degree. We do hope that another program will come from this faculty so that we can, let's say, better compete in the future. I think I will not take our respected resource persons moment. I would like to hand over later on to the resource person so that they can share their thoughtful knowledge, their thoughtful practice in the fields of pharmacies. I think that's all I can say. I do hope that what we carry out today can bring fruitful impact not only to us all presenters, participants, but also to the world of pharmacies. Thank you very much.
International.
Thank you very much, sir, for your inspiring word and for officially opening this seminar.
Ladies and gentlemen, before we proceed to the main session, we would like to
invite all distinguished guests to join us for a group photo to commemorate this special occasion. May I invite all guests and participants to please stand at your place. For our online participants, we kindly request you
to turn on your camera for a virtual group photo. Our technical team will assist in capturing this moment. Please smile and stay on camera for a few seconds. I will lead this photo session. The photo will be taken in 3, 2, 1. Thank you very much. Mr. Vice Rector, with respect, we would like to inform you that you are welcome to remain here with us, or you may leave the room to attend other duties. Ladies and gentlemen, we will now proceed to the
first session, which includes 2 keynote presentations and discussion. This session will be guided by Apotek Ninyoman Yudianti Mendra, SFAM and ClinFAM, a respected academic and clinical pharmacy practitioner. We kindly invite Ms. Yudianti Mendra to take your place on stage.
How are you today?
Little bit nervous, but fine.
But fine, okay. Miss Dian, first of all, please allow me to introduce yourself first. Miss Apoteker Ninyoman Yudianti Mendra, SFAM M ClinFAM,
is a lecturer at the Department of Pharmacology and Clinical Pharmacy, Fakultas Farmasi, Universitas Mahasaraswati, Denpasar. She completed her professional and clinical pharmacy education at Universitas Gajah Mada. Ms. Dian has conducted and published several studies that support the practice of pharmaceutical care. Without any further ado, Ms. Yudianti Mendra, the floor is yours.
Thank you, Mrs. Sasadera, for the introduction. Good morning, ladies and gentlemen. Okay, my name is Dian, as your moderator in this international seminar today. This seminar is also attended by over 900 participants and attended by hybrid setting. So I would like also to welcome those participants who join us virtually. Hello there, via Zoom online. Thank you for the participants joining us on site and online in this great session today. In this first session, I will guide the discussion with 2 esteemed speakers who will present the interesting topic related to the patient-centered care and self-management in adolescent type 2 diabetes. Before we start the seminar, I also want to share quickly our first session agenda. It will begin with the introduction, then continue the presentation from the first speaker for 60 minutes, then continue with the second speaker for 60 minutes, and the last one is Q&A session for 30 minutes. Now, I would like to invite our first speaker. Please welcome Dr. Apoteker Yunita Nita, SSE M.Pharm. Okay, so I met Mrs. Yunita. Bu Yunita, can I call you Bu Yunita? Okay. I met Bu Yunita yesterday. For your information, Bu Yunita yesterday in 3 days ago, also as being a chairperson in a huge event called ASEAN Conference on Clinical Pharmacy. So congratulations for your duty, Mrs. Yunita, and welcome to Universitas Mahasaraswati Denpasar. How are you today, Mrs. Yunita? Thank you. Okay. Mrs. Yunita is not alone today, so I would like to invite our second speaker. Please welcome Dr. Wong Yue Yen. morning, Dr. Wong. Finally, we can meet in a person, right? So I make a lot of contact with Dr. Wong before via WhatsApp. So we can meet finally in a person today. Also in Bali, we also use Om Swastiastu for welcoming persons. So Om Swastiastu, Bu Yunita and Dr. Wong. Welcome to Bali, especially to Unmas Denpasar. Maybe it's your first time to Unmas, right? Okay. This is a great opportunity for me to share this big stage with Bu Yunita and Dr. Wong. So I will hope this session will go smoothly. Okay, let me begin the first session. The first session will be presented by Mrs. Yunita. Mrs. Yunita, please allow me to introduce yourself. Okay, Dr. Apotek Yunita Nita SSEM Farm. She's a lecturer of the Fakultas Farmasi Universitas Airlangga. She got bachelor's degree and profession at Universitas Airlangga and her master degree at Curtin University and also the PhD at Universitas Airlangga. She is also a board member of ACCP, Asesor Plan PTKes and also member of Pengurus Daerah IAI Jawa Timur. Her last publication is buku Dasar-Dasar Akuntansi untuk Apotek and many more. For today's presentation, Mrs. Yunita will present. The topic is how to organize information for high risk implementing patient-centered care. The presentation will take for 60 minutes. Yes, and without any further ado, Mrs. Yunita, the floor is yours.
Good morning, everyone. Om Swastiastu. I hope everyone is ready and happy today because we start the day with the rain. So yeah, I'm still very happy. However, it will be very
good if I can go to the beach before I came here, but yeah, I cannot because of the rain. Okay. So, before start the presentation, I would like to actually mention again how deeply very grateful I am for the help given by Mahasaraswati University for the SCCP conference that has just ended last Saturday. We've been very happy because of all the help and all the contributions of Mahasaraswati University. So please give applause to Mahasaraswati University. Okay, thank you. So I'm also very thankful to be invited today for the seminar, and I was like looking at Dr. Wong just now. Oh, 900 participants. That's pretty big actually. Even more than the SCCP participants. Yeah. Okay, so today I'm going to talk about how to organize information for high-risk patient, implementing patient-centered care. So, next please, can you help me with the PowerPoint because this. So, today I'll be talking about a few key points. The first one is directly stated in the title of my talk is who is the high-risk patients, what is the key steps in ensuring medication safety, and what is the medication review, patient medication reports, and how to empower the patients. So next please. So who is actually the high-risk patients? Because we are talking about this. A high-risk patient is someone who is especially vulnerable to medication-related harm due to their health status, medication regimen or other risk factor. Pharmacists, as we are all here today, play a critical role in identifying and managing these patients to prevent adverse drug events and to ensure safe medication use. Medication harm is experienced by up to 30% of hospitalized patients, of which 7% experience severe harm, and pharmacist actually is the one who can do the review to mitigate this harm. Next, please. So, which patient actually fall into this criteria? One of it is the one who got polypharmacy. A patient who take multiple medication can increase the risk of drug interaction and also confusion. And also patients with chronic condition, they often require a complex regimen, while age-extreme patient, which is the elderly and pediatric patients, with who they metabolize drugs differently and are more sensitive to dosing error. Also, patients with impaired cognition or literacy, they usually have difficulty in understanding instruction, and this can lead to misuse and problem. And also patients who have history of adverse drug events or hospital admission, they also have the indication or indicates a pattern of medication-related complications. Also, the last one is the use of high alert medication in those patients is to include anticoagulants, opioids, insulins, chemotherapy agent, and lithium can actually lead to a danger or a risk. Next, please. So, as a pharmacist, what can we do? I would like also to mention that in the talk today, I will especially focus on the pharmacists in community setting. So, for you who is working in the community pharmacy, so you can learn what can we do. The first one is actually do condition review, and then patient counseling, monitoring, alerts and flags, and collaboration. I'm going to talk some of it here later on. Let me try this thing first. Oh yeah, it works. Sorry. So there's one paper which showed the impact of pharmacies in high-risk medication management, which actually enhanced the patient safety. From the result of the study, it is shown that the number of adverse drug event incident before and after pharmacist intervention is actually show a decrease, and it is a significant decrease. And then also hospital readmission rate before and after pharmacist intervention also shows a decrease, and it is also significant. Lastly, the medication adherence scores before and after pharmacist intervention also show significant decrease. I will show one case study to actually highlight what I'm going to talk today. So there's a patient, and the name is Mr. Polly. He is a 65-year-old woman, came to the outpatient clinic complaining of abdominal pain and dry stools. She had a heart attack 5 years ago. At her previous visit 3 weeks ago, she was complaining of muscle pain, which developed while working on her farm.
was
He was given a non-steroidal anti-inflammatory drug, diclofenac,
and
and her other
medication
medication being aspirin and pain medicine for her heart condition, which is simvastatin, and then ACE inhibitor and a beta blocker, atenolol. She was admitted to hospital as she developed symptoms of blood loss such as fatigue and dark stools, and she was provisionally diagnosed as having a bleeding peptic ulcer due to her NSAID, and her doctor discontinued diclofenac and prescribed omeprazole, a proton pump inhibitor. Following her discharge, her son collected her prescribed medicine from the pharmacy. Among the medicine, he noticed that omeprazole had been started and that all her previous medicine have been dispensed, including the NSAID. As his mother was slightly confused and could not remember exactly what the doctor said, so the son advised his mother to take all the medications. So after a week, her abdominal pain continued and her son took her to the hospital, and the clinic actually confirmed that the NSAID, which should have been discontinued in the first place, had been continued by mistake. This time, Mrs. Polly was given a medication list when she left the hospital, which included all the medications she needed to take, and was advised about which medication had been discontinued and why. So there are five key steps in ensuring medication safety. The first one is to appropriate prescribing and risk assessment, and the second one is medication review. The third step is dispensing preparation and administration. Fourth step is communication and patient engagement. And the last one is medication reconciliation care transition. I will not talk much about the medication reconciliation
because I believe that will be Prof. Syed topic, right? So, the first steps, remember that patient, Mrs. Polly, the appropriate prescribing and risk assessment, we can do assessment, and then we should know that the aspirin and NSAID without the gastroprotective agent left Mrs. Polly at an increased risk of gastrointestinal bleeding, while NSAID can also increase the risk of cardiovascular events, which is of particular concern as he had had a myocardial infarction 5 years ago. So move to the next step, the second step, the medication review. There should have been a review of medications, particularly as Mrs. Polly was prescribed aspirin and diclofenac together. The hemodynamic changes following blood loss should have also prompted temporary stopping the ACE inhibitor before restarting once the episode of blood loss has been resolved. So on the third steps, the dispensing preparation and administration, this is a high-risk situation as the medication has the potential to cause harm. However, the medication was continued after discharge when the patient transitioned from hospital to home. So dispensing this medicine and its administration caused serious harm to Mrs. Polly. On the fourth step is the communication and patient engagement. The decision to discontinue the medicine was not adequately communicated either to the other healthcare professional, including the nurse or the pharmacist, or to Mrs. Polly. That's why Mrs. Polly did not know that she actually needed to stop NSAID. The last step, the medication reconciliation. Diclofenac, the NSAID that can cause gastrointestinal bleeding and increase the risk of cardiotoxicity and had led to this hospital admission, was discontinued, and this information should have been communicated at the time of discharge in the form of medication list or patient health medication record. So we are, as a pharmacist in the community pharmacy, need to actually communicate with the pharmacist in the hospital, probably in the form of medication list, so we can avoid medication error. But then I will let Prof. Syed to explain in deep about this. Talking about medication safety, I would like also to highlight what is medication error and what is adverse drug event. We can see from the graph, hopefully you can see it properly. We can see on the left side, the adverse drug event can cause injury. And we divide it into two parts, the adverse drug reaction and the preventable, the adverse drug event we can divide by two, adverse drug reactions and preventable adverse drug event. The adverse drug reaction is not preventable because of the inherent risk of the drugs, while the preventable adverse drug event and the other two part is actually under medication error. So you can see that there is an overlap between adverse drug event and medication error. Medication error is actually preventable. So I see there's students here, right? Are you a student? You're students or not? Yeah, okay. So I like to ask my students, do you know what's the difference between adverse drug events and adverse drug reaction? Do you know what's the difference between drug-related problem and medication error? And then we kind of have fun in class because we play with the definition and then we'll give like a quiz or something. So yeah, you can see that it is actually overlapping between adverse drug event and medication error. So looking at the definition, to make it clear, the adverse drug reaction by definition by WHO is a response to a drug which is noxious and unintended and which occurs at doses normally used in men for prophylaxis, diagnosis or therapy of disease or for the modification of physiologic function. So it is used in normal dose. Please pay attention that the ADR is used at a normal dose. While adverse drug event or ADA is any untoward medical occurrence that may present during treatment with a pharmaceutical product but which does not necessarily have a causal relationship with this treatment. So it is including misuse and abuse. So it is not used in the normal dose. So medication error is any preventable event, so this is the key, it is actually preventable, that may cause or lead to inappropriate medication use or patient harm while the medication is in the control of the healthcare professional, patient or consumer. So an ADR is a type of adverse drug event whose cause can be directly attributed to the drugs and its physiologic properties. ADRs occur despite appropriate prescribing and dosing because it is the inherent property of the drug. While ADA or adverse drug events may also be associated with the inappropriate use of the drug or other confounders that occur during drug therapy but are not necessarily caused by the pharmacology of the drug itself. So a causal relationship is suspected for an ADR but is not required for an ADA. ADA may also be caused by medication error. So continuing with the key step in ensuring the medication safety, I will talk about the medication review, the second step. So medication review is a structured evaluation of patient medicine with the aim of optimizing medicine use and improving health outcomes. This entails detecting drug-related problems and recommending interventions. A multidisciplinary activity whereby the risk and benefit of each medicine are considered with the patient and decision made about future therapy. So when we do medication review, we need to understand where the information comes from. The first one, of course, from the patient itself, and then you can gather information also from the family or the caregiver, and also from the medications and the medication list, and also other sources. Maybe, for example, if your pharmacy have a connection with the database from the insurance company, probably BPJS or others, then you can use that for the source of information. Or even better, if you connect it to a hospital, so you can have information on the patient medication record of the patient, but probably that's not the common situation in Indonesia. And then what should be documented? You need to document product related, and then all activities related to the provision of pharmaceutical care. For example, if you need to communicate with the doctor, if you need to actually do a follow-up with the patient, maybe by phone, or you want to come to the patient home, like doing a home visit, and etc., you do need to document that. And you also need to document the drug-related problems. Drug-related problems documented should include identification of the drugs, what is the disease, do the patient have allergies, what type of problem that is happening, and then you need also to write down what is the service that you already perform to actually resolve the problem, and then what is the recommendation, and also what is the potential outcome coming out of it. Other activities that need to be documented also, besides those, one is, like I mentioned before, consultation with other health professionals. When you are in the community pharmacy, sometimes we do need to call the doctors to make sure or to clarify anything, to make sure that the problem can be sorted out. And then counseling. If the patient have problem, yeah, you might need to counsel the patient and try to talk to patient, and then to make them understand and what can be done to actually resolve the problem. And then also the assessment of patient understanding. For example, Mrs. Polly, that previous case that I presented, she actually did not understand the instruction. So she did not understand that her NSAID should be stopped, that the NSAID is the one who caused problem, because she does not understand. So we do need to assess whether the patient is have a good understanding, because in Indonesia sometimes the patient, especially maybe in Java Island, they will say "nggih, nggih," or just nod the head, but then they actually have no idea what you are talking about. So you do need to assess the patient understanding. Then also, if you do a self-care consultation or advice, you do need to jot it down and put it and document it. Or if you refer the patient to other healthcare professional, for example, if the patient come for self-medication, then you advise the patient to go and see the doctor because of the condition is needing a referral. So yeah, you need to put it down and you need to write it down and to be documented. And then also, if you have patient-related activities which require an unusual amount of time, for example, if you need to call the patient and explain so many stuff because the patient is not the one who come to the pharmacy, you do need to actually document that. That it is in the form of telephone call and when and what is informed to the patient. And also the last one is any activities that is important to communicate in the future. How to document? After we know what to document, and then we need to move on to the what to document. Of course, the basic things is identification of patient and encounter. So when did you see the patient, what date, and then who is initiating the encounter, the person responding to the request, is it you or your fellow pharmacist, or maybe you have 3 or 4 pharmacies in your pharmacy, then you do need to actually write down who actually meet the patients. And then how long have the conversation and how long the time needed to actually deal with the patient. And then the level of significance, is it minor, moderate, major, or life-saving? Can you help with next, please? Oh, it's up there. Okay, thank you. So the second one is we need to identify the problem or the need with regard to medication, the disease and allergy. And then the third one is identification of the activity, service or care provided. What is the action taken by the pharmacist? Do you call the physician? Do you actually call other healthcare provider and so on? Or is there any intervention performed, referral to appropriate healthcare professional, or maybe you suggest a medication or other things? And then also identification of the recommendation and potential outcomes. You also need to put the SOAP notes, so you can put subjective, this is the non-quantifiable data, subjective observation and how the patient feel, and then objective, which is the facts, for example, data lab, and then assessment, what is the interpretation of the S&O findings, and lastly is the plan. What is the action, intervention, recommendation, and follow-up that you actually plan to be given to the patient. So where did you put the document in? If you are a pharmacist working in community pharmacy, then I believe you have patient medication records. So if for the students, yeah, you do need to have patient medication records. For the pharmacist audience, I believe that we do have patient medication record in the pharmacy. I'm also a practicing pharmacist in the community pharmacy. Then one of the requirement to actually get the permission, surat izin apotek, one of the requirement is actually we need to have a patient medication records. There's an example like how we actually make, what is it like? You can check it in the regulations. Yeah, they do give example of the patient medication record. So what is the advantages? The PMR is actually help us to correct records. By have a proper documentation, we actually are able to notice if there is something wrong. And also it provides a base for giving patient advice. If we don't know what is happening with the patient, we don't know what to advise or counsel or give information. And also PMR can detect errors if we document correctly, and then we can see that the patient, oh, Mrs. Polly actually have NSAIDs, and then now she developed gastrointestinal problem, so probably it is due to the NSAID. If it is not written there, you cannot actually realize that this is the connection. And then the last one is knowing the pattern of drug usage in a community pharmacy is also one of the advantages of having a patient medication record. Why do we need this? This is good in the management area, so you know what is drugs to be purchased, or what is the community like to use, or what is the main medication that the doctor practicing around your area actually mostly use. Okay. So what is the contents of the medication records? You need to put down all treatment, including over-the-counter medicine. I often found out that the pharmacy, in community pharmacy, only wrote down the prescription medicine. It's actually not enough. We do need to put the OTC medicine also in PMR. So sometimes the problems not come from the prescription medicine, but it's actually come from the over-the-counter medicine. Then of course we need to put the patient name, the address, the age or date of birth, telephone numbers, who is their GP. Here in Indonesia we have BPJS, right? So their primary doctor is already decided. So I mean, it is just a specific place that the patient can go to their primary care center, whether it is a puskesmas or it is a clinics, a private clinics, or a dokter keluarga or family doctor. So yeah, we need to put down the GP and then drug history, hypersensitivities, and current medical problem. So what is the priority? The priority is a certain group of patients. For patients over 60 years old and children under 12 years old, we need to pay more attention. And then some disease group, for example, asthmatic, epileptic, on patient on certain group of drugs, anticoagulants, oral contraceptives, or steroids, or patient with special needs, someone with penicillin sensitivity, multiple therapy, or confusion. So how do we organize the information? We need to categorize patient data clearly, and then we need to also organize a timeline and monitoring tools. So how are we going to monitor those patients? Also, you need to include care plans and instruction. So you are welcome to actually reorganize your patient medication record. You don't necessarily need to have your patient medication record exactly like what is already put in the Permenkes or whatever it is available from. You can actually revise and make it as you need, according to your need. And then you need to prioritize critical information, and if possible we can link record across system. That will be great, but maybe that's not happening very soon. So, and then lastly, don't forget, the PMR is patient data. So you need to make sure you maintain data security and consent. You have to put your data in a proper place, because sometimes community pharmacies still use print out patient medication record, and then we just put it like laying around in the pharmacy. So please don't. Or if it is in the computer or it is computerized patient medication record, you also do need to make sure that there is a data security and consent from the patient. There is one best practices that I get from one of the sources in the internet, how to manage your high risk list and proactively. So the best practice is, the first one is you need to have team discussions regularly to actually discuss the high risk patients. Whether there is opportunity to actually decide on the actions, what are you going to do with these patients. So you need to actually engage with your team. And then the second step is actually, what are you going to do next? So define next steps for each high risk patient. For example, Mrs. Polly, now you need to put in your mind that Mrs. Polly needs attention because she doesn't really understand instruction, and then she already experienced severe adverse drug events. And then you do need also to meet with your team to create actions, and then it must be specially tailored for every patient, because there's no patient that is the same. And then the third step is actually to reach out. You reach out to each high-risk patient on a regular basis. This is have these advantages. Why? Because sometimes in the community pharmacy, there's only one of us, one pharmacist, and 2 pharmacy technicians, or sometimes if you're lucky, we can have 2 or more pharmacists. Then if I'm alone, then who do I talk to? Talk to myself? Yeah, probably, yeah, but we still need to do this. So if you have a team, our workload probably pretty high. So if we do need to reach out to the patient, it will add a task. I mean, it will add to more things to do for us in the pharmacy. But yeah, it's a must. Yeah, a high-risk patient must be taken care of. So to reach out the patient, you can decide how frequent and which patient that you are going to reach out. Then the last step is implement a tracking system. You need to stay organized. If not, you need to create a system. If not, you have a bulk of patient medication record and you have no idea which one is actually the high-risk patient. So yeah, we do need to create a system. If it is using IT, that will be the best, because you can get information more easily than to open print out or a hard copy patient medication record. Okay. So the last part is actually how do we empower the patients? Why do we need to empower the patients? As we say, community pharmacy in Indonesia mostly have a limited number of pharmacies. Okay, we know that there is a gap between the demand and the availability of the pharmacies. So you do need to empower your patients. How do we empower the patient? You can actually adopt the WHO 5 moments of our medication safety, where the patient need to know about their medicine. The first one is that you need to teach the patient. First step is starting a medication. You need to teach the patient what is the name of this medication and what is it for. So patient need to understand if she has more than one medicine, like the polypharmacy one, probably the patient have 7 or 8 medicine. You need to actually help them to identify the name of the medication and what is it for, and then what is the risk and possible side effects. One day it happens to me, I have a patient who been given metformin by the doctor for the PCOS problem, and then she mistakenly thought that the medicine is for high blood glucose. So then she actually, when she doesn't feel good, then she skipped the metformin because she was afraid that she will got a low blood glucose level, which is not true actually. So yeah, we do need to communicate with the patient and make them understand what is the medication for and what is the possible side effects if they thought something, if they pick up something from the neighbors or read something wrongly. Yeah, we need to actually straighten things up. So is there another way of treating my condition? That's the thing that the patient also need to know. Have I told my health professional about my allergy and other health condition? We need to actually empower the patient and state and make the patient understand. Every time he go to the pharmacy or go to see the doctor, she or he need to inform about the allergy and what is medication they are using right now. So the pharmacist or the other healthcare professional aware of the potential problem that may come up from another problem that is still happening. Okay, then how should I store this medication? Storing medication is a very important thing. Why? Because some of the medication error happen because of the storage problem. If the patient put the medication without label or proper labeling, other member of family can actually mistakenly took the medication and swallow it, thinking that it is actually a paracetamol or something something common. So yeah, how do he store the medication is important, and also like medicine with a special storage condition like insulin and everything must be stored accordingly. The second moment for medication safety is actually taking my medication. Patient should understand when should she take this medication and how much should she take every time, and then is there by drinking or through other route? Is there anything related to food and drink that the patient should know while taking this medication? For example, if she should avoid iron supplementation, for example. So yeah, patients should know. And then what should I do if I miss a dose of this medication? Sometimes patient is very simple in thinking. They thought that, okay, so I can double it. Because I forgot, then I can double it, and it will create problem for a certain medicine. Okay, so and then what should the patient do if they have side effect? Should they stop the medicine? Should they call you? Should they go to the doctor, etc. and etc.? We do need to inform them. Okay, the third moment is adding a medication. Do the patient need any other medication? Is there any addition that she need? For example, maybe diabetic patient is, or the blood glucose level is not in control. Yeah, we need to actually refer the patient to the doctor. Probably she need other medication, or maybe there's other thing happening, probably because of the adherence problem. Some of the problem, especially elderly past patients, sometimes it comes from adherence problem. It's not because of the medication doesn't work, but it's because the patient doesn't take it correctly or properly. So have I told my health professional about the medication I'm already taking? So have the patient actually inform the doctor or other health professional, and then can this medication interact with my other medication? So if the patient got a contraception pill, we do need to inform the patient. If she takes other medication, please inform your pharmacist that you take this medication, this contraception pill, just in case there is an interaction that can actually make the pill doesn't work, make the contraception doesn't work. Or will I be able to manage multiple medication correctly? So if the patient have a problem in taking too many medication, you do need to help them by providing a tools. Probably you can give a pill box with the information like which one to be taken at what time, and then but the patient need to actually refill the pill box like once a week, probably every Sunday, or you can arrange the daughter or the son of the elderly patient to actually arrange the medication weekly. So their grandpa, grandma, parents can actually just need to open the pill box and then take the medication. So it is easier for them to actually recognize whether they forgot to take the medication or not. Okay. So the fourth moment is reviewing my medication. do the patient actually know that she needs to keep a list of all his medications? Why? Yeah, so she understand, because sometimes there's a problem. One of our patients just discharged from the hospital and she got 2 types of insulin. And then after discharge from the hospital, she came to the pharmacy to buy something else. And then she told us that she just discharged from the hospital and got 2 insulin, and then she asked how to use. Is it the same with the the previous insulin that she got before admitted to the hospital? And then we got alarmed by that question, so we asked her to actually bring the insulin at home to our pharmacy. And then we check, it's actually the same 4 insulin, 2 is on the same insulin with a different brand name. So lucky this patient haven't actually used all 4. So it'll be very dangerous. So yeah, so they do need to, I think Pak Seth will explain about medication reconciliation, but it is a very important thing, and we were kind of actually shocked because of what will happen if she actually took all of that for insulin. So does the other question is, does a health professional check my medication regularly, or am I taking any medication I no longer need? Does a health professional check my medication regularly? How often should my medication be reviewed? Yeah, if she has a good relationship or a good pharmacy, and she often come to the same pharmacy again and again, and the pharmacy have a medication record, so the pharmacist can actually detect an error if she actually put everything documented nicely in the medication record. And then the first moment is stopping my medications. When should I stop each medication? Should I use this like forever, or should I use it only when it is necessary, or should I use it only when the symptom persists? Should any of my medication not be stopped suddenly? Is this PRN1, Prorenata? Is it only for specific symptoms, or when the symptoms resolve, you no longer need to take the medication? Or what should I do if I run out of medication? We just ran a study in a puskesmas, few puskesmas, primary healthcare center in Surabaya, and then we actually found out sometimes patients did not go to the puskesmas on time because they have probably a problem, nobody take them to the puskesmas, and etc., etc. Then they actually buy their medicine outside, buy it from the pharmacy, because the pharmacy may be more accessible in terms of distance. So she tried to replenish the stock by buying, but then we found out some of the patients actually bought only one medication. For example, she usually got 2 or 3, she just bought one that she thought is the most important. Because when she bought from a pharmacy, she need to pay out of pocket money. Where she got it from the puskesmas, she doesn't need to pay because it's free. So yeah, there's a lot of problem with regard to stopping medication, or how she do if she run out of medication. We even have a study done that show a patient, we do a pill count, and then halfway the medicine gone. She was supposed to take it for 30 days, but halfway, I mean on the 15 days, the medication finished already. So we was like so scared, what happened with this patient? She believed that if she took more, then she will getting better even faster. So yeah, that's pretty scary actually. So the patient also need to know if I have to stop my medication due to an unwanted effect, where should I report this? So the patient actually do need to communicate with the pharmacist and the doctor when she stop the medication for whatever reason. Or what should I do with leftover or expired medication? The easier thing is just bring the leftover or the expired medication to the nearby pharmacy so the pharmacy can actually discard it accordingly. But not too many pharmacies offer that service. Yeah. A long time ago, I think in Surabaya, I know that there is a program that is called the discharge medication program, where patient can actually put their medication to the pharmacy and the pharmacy will bring it to the respective Balai POM, the nearest one, and then they will actually menghancurkan obat tersebut. Yeah, that's a very good program that I believe it should be encouraged to happen everywhere. So with that, I conclude by saying thank you of your attention.
Thank you, Bu Yunita, for the insightful presentation. So, if I can conclude your presentation, your talk today, does the pharmacists play a critical role, right? Critical role for identifying and managing those patients to ensure the safe of medication or medication safe, especially in high-risk patient, including a patient more than 65 years old, and then polypharmacy, using a high-risk medication and so on. And the role of pharmacists, including medication review, patient counseling, monitoring, alert, and collaboration. So there are many tasks to do for us as a pharmacist. You are a young generation of pharmacists. There are many tasks to do to ensure the medication safety for all of the patients, especially high-risk patients. Okay, thank you, Mrs. Yunita, for insightful presentation. And this is a warning for the online participants who want to ask questions for both speakers. Please write your question on the comment section, or you can asking directly for both speakers with raised hand first. So do with the on-site participant, if you want us to the both speakers, you can raise hand and mention your name before you state the question. But hold on, yeah. Please keep your question because we are now moved to the second speaker. Dr. Wong, please allow me introduce yourself first. Committee, please help me to, okay, thank you. Dr. Wong Yuet Yen, she's a senior lecturer in University Teknologi Mara in Penang branch. She's got her registered pharmacy since 2004, Master of Pharmacy in University of Strathclyde, Scotland, Master of Clinical Pharmacy and PhD in University Science Malaysia. Dr. Wong, was awarded as Best Paper and Presentation in the 3rd International Conference of Science, Ethics and Civilization. For today's presentation, Dr. Wong will present with topic is Empowering Self-Management in Adolescent Type 2 Diabetes, a patient-centered approach to sustainable outcomes. The presentation will take for 60 minutes, and without any further ado, Dr. Wong, the floor is yours.
Hi, good morning everyone. How are you today? Macam tak bersemangat saja. May I kindly ask all the participants, including those online, to stand up, stretch a bit, because you have been sitting for 60 minutes or so, right? Okay, so yeah, feel free to stand up, stretch a bit. You know, this really has something to do with the topics that I'm presenting today, type 2 diabetes mellitus. We need to break the chain of sedentary lifestyle. Just move around. Feel free to move around. Okay, thanks for your cooperation. You may remain seated. Okay, hi again. Good morning to those participants here and also those online, and also my colleagues and students who are at Malaysia right now. Okay, so what I'm going to do with you today is that I would like to share some insights that I have gained while working with my co-investigators in exploring what are the needs, what are the perceived needs and barriers when coming to young people in managing their diabetes on a daily basis. So, okay. All right. So throughout my presentation later, instead of using the term adolescents, I might interchangeably use the term young people, which broaden the scope a bit to include those aged 10 to 24 years old, according to WHO and UNICEF definitions. Now, these are the outlines of, These are the outlines of my presentation. I'll walk through with you what is diabetes mellitus. I hope everyone well aware. We are pharmacy students, right? And we are pharmacists. And then what I'm going to focus a bit more is the new terms, the young onset type 2 diabetes mellitus. Okay. Perhaps I would like to see a raise of hand. How many of you have a family history of diabetes mellitus? Your parents, your grandparents has got diabetes mellitus. I myself. No? Indonesians are very healthy. We in Malaysia, not so. 50% of Malaysians are currently in overweight or obesity. So which is a key driver to type 2 diabetes. So we need to pay a lot more attention in managing type 2 diabetes here in Malaysia. Next, what I'm going to talk more with you is what is diabetes self-management. It's actually important for patients diagnosed with diabetes. And then I will also highlight why is it so important for patients with type 2 diabetes to receive self-management educations and support. So I'll also bring a little bit based on the experience of the pharmacists in Malaysia, particularly the diabetes mellitus medication therapy adherence clinic from Malaysia setting, to perhaps give you some insight what you can do in your future. And when talking about patient-centered approach, it's very important that we understand what the young people want. What are their preferences for diabetes self-management education? And perhaps I will end my presentation with a few key notes, key taking message for you to ponder, as well as for myself to ponder what we can do in the future. Okay, so what is diabetes mellitus? It's basically a chronic disease, right? It's a metabolic chronic disease characterized by hyperglycemia, high blood glucose in our body. And is resulted from either it's a progressive disease that resulted from insulin deficiency or insulin resistance. Now we know that there are many types of diabetes mellitus out there, but the most two common types are type 1 and type 2. And even more common is actually type 2, which account for about 90% of all the diabetes mellitus cases. Now the type 2 is commonly known as insulin dependent, usually happen in the very young children because resulted from immune destructions. It's an immune disease, okay, because of the destructions of the pancreatic beta cells, so they don't have any insulin in the body at all. While for type 2, usually resulted from insulin resistance itself or insulin deficiencies. And there are risk factors. Okay, studies have shown that these risk factors are the ones that actually drive type 2 diabetes mellitus. For instance, overweight, obese, as I mentioned just now, okay, sedentary lifestyle, okay, when we get older, 40 years and above, when we have parents, although they love us, they also pass over genetics, diabetes genetics to us, so we tend to also have higher risk of getting type 2 diabetes later. And if you are pregnant with diabetes, your risk of getting type 2 diabetes in 5 to 10 years' time is also higher compared to those without gestation diabetes mellitus. Now we are well aware that landmark studies like DCCT, UKPDS have shown us that well-controlled blood glucose is very important, because insufficient blood glucose control can cause complications, including microvascular complications, macrovascular complications. And actually, the most people with type 2 diabetes, so people with type 2 diabetes, they don't die because of high blood sugar, they die because of coronary artery diseases. Okay? And studies shows that those with type 2 diabetes mellitus, they are 2 to 4 times more likely to die from cardiovascular diseases compared to those without diabetes mellitus. Now the International Diabetes Federations, usually they update their statistics on a yearly basis. Currently, adults aged 20 to 79 are found to have diabetes mellitus, equivalent to about 589 million people worldwide. Okay? So what I would like to highlight here is that most of them actually happen in the lower income countries, such as in Indonesia and of course Malaysia. And managing diabetes mellitus is really costly. It costs a lot for the countries. Okay, so this map, as you can see, all the percentage are increasing. None of it is decreasing. This is the projection made by IDF in the next 25 years or so. This is the number of people worldwide that will get diabetes mellitus. And what is so alarming is the number of percentage which we observe higher are those from lower and middle income countries, like in Malaysia. Okay. So in Malaysia, the national statistics have consistently highlighted increasing trend of type 2 and type 1 overall diabetes mellitus in Malaysian populations. So currently we have 15.6% of adults diagnosed with diabetes mellitus. Okay, so what is also concerning is more than half of them do not have good sugar control. And another concern of message that I would like to bring over here, if you can see here on the screen, it is also affecting the young people. Type 2 diabetes was initially thought as a disease that usually happen in older person, right? Now no more. We see more and more young people getting type 2 diabetes. As young as 8 years old in hospital were found to have type 2 diabetes mellitus. So this brings to the new terms named as young onset type 2 diabetes mellitus. Now, the young onset type 2 diabetes mellitus is commonly defined as those diagnosed with type 2 diabetes younger than 40 years old. And collectively, there are studies who shows that those young onset, they have poorer prognosis. They have more complications, they die earlier, and also more difficult to manage. Okay? So in terms of the predictors or the factors that contribute to young onset, seems to consistent with the usual onset of type 2 diabetes, but we observe more obesity, overweight in the young people that contribute to young onset type 2 diabetes mellitus. Okay, so the trends among the young people, it's continued to increasing. That's why it has now become a concern. Okay, so why is it a concern? If you see the characteristic of young onset diabetes, they have more rapid deterioration of beta cell functions comparing to usual onset. Those with young onset, they have 20 to 35% destructions in beta cell functions when first diagnosed, compared to 7% in usual onset diabetes. And therefore, it leads to poorer glycemic control and more glycemic variety among the young onset diabetes. So this will also resulted in young people getting insulin therapy faster. So 50% of them will get insulin therapy in 2 to 5 years time after diagnosis. Imagine at your age, the patients need to inject insulin every day. So how you feel about that, all right? And young onset diabetes mellitus, they prone to get complications earlier, particularly in the 3rd and 4th decades of life, whereby this is the time which is the prime of our life year, right? You need to work, you need to grow money, you are looking to enjoy life. So that's the time that the young people get complications. And recent studies that actually gather data from the developed countries, they shows that those who diagnosed with diabetes younger at age, they are 3 to 4 times more likely to die faster, okay? Now, in terms of the management for young adults diabetes mellitus, it is still very largely depend on the existing management guidelines, which is developed based on more older adults. Okay, so the findings are still derived from more older adult types of guidelines. Okay, so the guidelines have consistently highlighted that to manage diabetes mellitus, we require a multidisciplinary care team. Okay, so usually I would like to summarize the diabetes management guidelines in a simple, easily memorized acronym known as ABCDE. This is actually derived from Canada Clinical Practice Guideline. A referring to HbA1c, which is glycemic control. B, blood pressure. C, cholesterol. D, drugs, exercise, and food. So this means that multifactorial management need to be in place. And if you can recall just now, I mentioned, right, diabetes mellitus patient, they don't die because of high sugar. They die because of cardiovascular disease. So we need to aggressively manage all the cardiovascular related high risk factors, BP, cholesterol. So these are the things, risk factors that we need to look into when managing patients with type 2 diabetes. Okay, however, the current guidelines, as I mentioned, are still largely based on usual onset of diabetes mellitus. There remain a lot of unmet needs for these young people. They are less likely to be recruited for clinical trials. Therefore, the treatment options are still very limited. Apart from insulin, metformin, empagliflozin, GLP-1 but currently approved for young people are only 2, liraglutide and exenatide. So we don't have a lot of options for young people with type 2 diabetes mellitus. Okay, so another thing that I would like to highlight here and also been emphasized by Dr. Yunita just now, apart from medications, self-care, self-management is also very important, particularly for people with type 2 diabetes. Now, the American Diabetes Associations have highlighted that diabetes self-management is really critical to achieve good glycemic control. Diabetes mellitus, for patients with type 2 diabetes mellitus, they need to equip with 7 self-care behaviors. Number 1, healthy coping, medication taking, healthy eating, being active, to be able to monitor themselves, problem solving, and also reducing risk. So each of these self-care behaviors need to be empowered, okay, at the moment, right from the beginning of diagnosis. Okay, so if you do, for instance, venture into the literature, sometimes the literature, they use these 2 terms interchangeably, self-care, self-management. But in diabetes mellitus, we use the term self-management, referring to the tasks that the individuals with the disease need to do in order to control the disease. While self-care, referring to tasks healthy individuals that commonly do in the daily life in order to prevent from getting an illness. No matter how, these 2 terms are often used interchangeably. Okay, so I would like to emphasize that diabetes self-management is really patient-driven. What do we mean by patient-driven? It's really all the tasks, for instance, they test their blood sugar, they take their medications, whatever diet they choose out there, whether it's a healthy one or not healthy one, it's really patients to decide, not the healthcare professionals. Right? So in a previous UK report, basically it shows that on a yearly basis, the patients only meet the doctor, the healthcare professionals, about 3 hours. And majority other hours, 8,757 hours, the patients need to manage their disease on their own. So no matter how we want the patients to adhere to the medications, to take the medications, we cannot be with them 24 hours. Patients need to do the task themselves. So there come in what Dr. Yunita mentioned just now, empowerment. Okay, commonly defined as helping the individuals to develop their inner capacity to take charge of their own life. So patients with type 2 diabetes, they cannot not manage their disease on their own. They need to manage the disease on their own. So there come in diabetes self-management. So apart of that, I will also bring in a few more unique challenges that faced by young onset diabetes mellitus. So because their beta cell functions destroy faster, right? More rapid destructions of the beta cell functions, we notice that the glycemic control among young people is common. Okay? This could also because they transition from adolescence to adult care, whereby they are bombarded with new social responsibilities. They need to go for work, they need to attend universities, which are burdened by academic work, assignment, etc., that resulted in loss of medical follow-up. Okay? Another issue is that young onset type 2 diabetes commonly face is poorer medication adherence. Okay? So this most is usually due to different beliefs in terms of medications and also the reasons why they are they need to take up new social responsibilities while they are transition from childhood to adult care. And younger people tend to have poorer lifestyle. They exercise lesser, they eat not too healthy, and they tend to be more obese. And we also observe that the young people tend to suffer from diabetes distress more, because apart from managing their disease on a daily basis, they also need to cope with the different kind of change in terms of their social responsibility. Some may get married, for instance. They need to take care of their family members. So apart from that, they also need to spend time managing their own diseases. So all these actually contribute unique challenges to young people with type 2 diabetes mellitus. So in Malaysia, similar situations also reported in the literature. Young people tend to be not well controlled in terms of the blood sugar. They have higher risk of developing micro and macrovascular complications. Their self-care is poorer compared to even the adolescents with type 1 diabetes, and they generally have poorer knowledge in terms of their own disease. So at that time, which was a few years back, before we started our project in exploring what young people with type 2 diabetes do in Malaysia in managing their own disease. So the the information about young people were relatively scarce. So we were interested to know that time why young people with type 2 diabetes mellitus in Malaysia particularly cannot achieve their recommended goal. And we are interested to find out how they actually manage their diseases on a daily basis and what facilitators or barriers actually influence their decisions on a daily basis while managing their disease. So this is what we did. Okay, so we did a meta-synthesis. Meta-synthesis is like a systematic review, but meta-synthesis focuses more on qualitative studies. We aggregate the findings from qualitative studies. So what we found that the behavior of diabetes cell management among young people influenced by multifactorial factors, particularly those surrounding his or her environment, including intrapersonal, community, and institutions factors. So this is what we found in our findings. As you can see, it's really very complex. It's not just about medication taking. It's about all the factors surrounding the young people, including their relationship with the peers, with the parents, even with the school, the teachers, and also their individual motivation, knowledge, whether they have the skills. So all these factors, it seems like to act as what we observe as double prong. If they have these factors, it seems to push them towards diabetes self-management. If the factors is not present, so they tend not to perform the behavior. So we also carry out in-depth interviews with the young people as well as the caregivers, the parents of the young people diagnosed with type 2 diabetes. Our aim is to get to know them better. This, what we thought is that we need to find out what they really think before we can devise something that can help them. So it's important to find out what they think first. So we talked to a total of 16 young people. Most of them were female. As you can see, more than half of them, their blood sugar is not well controlled yet. Okay? And also we talked to parents, 11 of them. Most of them were actually mothers who are accompanying the young people for their medical follow-up. So these are the things that we have found. The trajectory of type 2 diabetes diagnosis, what they think, why they think they get diabetes, and what they have done in managing their diabetes. Okay, so this is what they say. For the young people, we notice that there are sort of two ways in terms of the diagnosis that contribute to the diagnosis: the unanticipated route and the anticipated route. The unanticipated one, usually the patients discovered when they have diabetes during the time of health screening, when they are about to entering university, or when they encountered something disturbing their body, for instance, unhealed wounds, so that prompt them for further investigations. Then they found out that they have type 2 diabetes. While for anticipated rule, usually come from the parents who already got diabetes. So because the parents has got experience already, so when they see their children experience all these symptoms, they will bring their children directly for these medical investigations. So that resulted in type 2 diabetes confirmation. So upon diagnosis, the participants, the young ones, reported that they really have a mixed reactions from sad, frustration, shock upon diagnosis. Some of them, because they were diagnosed too young, they don't know what to do. They have to rely on their parents. And some of them who are older one, and particularly with background of family history of diabetes, they tend to accept faster. So there are mix of reactions on how these young people get to know when they have type 2 diabetes. While the parents, some of them blame themselves because they never take care of their children, and some of them, particularly those with pre-existing diabetes, they think that it's actually written by the God, so they have to accept it. So for perceived causes of type 2 diabetes, both the young people and the caregivers, their thoughts are almost similar due to unhealthy diet and sedentary lifestyles. Of course, the caregivers, because they are more matured, developed, they have went through the process, they thought that it could be also due to genetic factors and also diabetes mellitus during the pregnancy. So this is what they have done to try to manage their disease. Most of them actually said that they have started to change their diet, but the way that they change their diet is usually reducing the portions. Not so much on, for instance, carbohydrate exchange, and also tracking the carbohydrates they are taking on a usual basis. In terms of physical activity, usually they said that they don't have additional other activities. Whatever they have in the school, they will just follow. Medication taking, usually what they do is they will keep the medicine near to site where they can easily see the medication that will remind them to take their medications. For glucose monitoring, we observe that only young people who are on insulin therapy and requested by doctors. So they don't proactively monitor their blood sugars unless it is requested by doctors or pharmacists to do so, right? Okay, so in terms of their perceived needs and barriers for managing their diabetes mellitus, we found 3 important themes here. Intrapersonal, meaning what internally what they think. Interpersonal, the interactions with people surrounding them, and also at community level. Okay, so for intrapersonal values, as you can see, it is important that all the patients with type 2 diabetes mellitus are equipped with knowledge and skills. So this will help them to manage their disease better, all right? And if the family members have consistent thoughts in terms of the disease, particularly on diet decisions that will help them to manage their disease better. Caregivers' involvement, social acceptance, and also the open discussions with the healthcare professional, meaning rapport, relationship with their surrounding, will actually facilitate them in self-managing their disease. So most of the young people, they tend to seek information online through social media and also internet, right? So that's what the young people inform us during the study. In fact, a recent study published by Singapore have actually find similar findings to us. Okay, so whereby the young people, they are experiencing multifactorial in managing their disease. All of this can actually affect how they think and whether they want to take actions to change their behavior. So we have walked through the unique challenges faced by young people with type 2 diabetes mellitus. And all of it actually affect their daily lives, their social life. So that's why diabetes self-management education and support is very important, and it is integral in diabetes care. So what is so good about DSMES is that studies have shown that it can reduce 4 times of complications, actually very impressive results. It reduced HbA1c as high as lower as 0.74%, on par with many existing medications. And the good things about DSMES is that there are no side effects, no recorded side effects for DSMES. So therefore, the American Diabetes Association basically advocate that DSMES should be offered right from the disease's diagnosis and should continually offered throughout the life of the patients. So in terms of the content, what we should teach or channel to the patients usually involve the disease and treatment options, and of course the self-care behaviors, including problem solving, decision making, goal setting. Okay, sadly, even though it's effective, DSMES utilizations and adoption is still very poor globally, even the developed countries. For instance, in a DAWN-2 study, which is quite a landmark study for type 2 diabetes, less than half of patients with type 2 diabetes have actually used DSME, and even lower percentage in US and UK. So even the developed countries, utilization is very poor. What about those of us in low and middle income countries? Probably even lower. Okay, so what I would like to go through with you in the next couple of slides is to reinforce we pharmacists can also play a role in offering and supporting diabetes self-management through the DSMES. So just quickly that I want to show evidence that pharmacists can contribute impact on diabetes type 2 diabetes self-management, because we practice evidence-based medicine, right? So I mentioned just now, pharmacists can contribute a role. I must bring in evidence to show you that. As you can see, this systematic review basically pull in 11 studies, and they have shows that all the interventions that led by pharmacists, it can reduce HbA1c, and on top of that, it also improve self-care behaviors among patients with type 2 diabetes. Okay, following on, I would like to draw on experience from Malaysia. In Malaysia, we have Diabetes Medicine Therapy Adherence Clinic, which pioneered by one of the speakers here, Prof. Shai. He's the pioneer of DMTech in Malaysia and is now widely available in Malaysia. So basically, the MTech, they will recruit mainly patients who are not well controlled, patients who are on insulin, patients who are not adhere to medications, patients who experience complications and complex regimens. You can see here, MTech is still focusing a lot of patients who are not well controlled, whom disease could be a bit more complex. What about those newly diagnosed ones, such as the young onset diabetes mellitus? So we have yet to see much information about MTech in Malaysia. Okay, so these are the common activities that MTech in Malaysia carry out. They will provide personalized patient education, medication adherence assessment, medication side effects evaluation, insulin injection techniques. They will also help patients to adjust their insulin and also review self-monitoring blood glucose reading. So this is usually what happens in the DMTech on a daily basis. Usually the pharmacists are the one to proactively identify who are the patients that they want to enroll them in MTech. Okay, so when they have identified the patients, they will send the patients to the nurses first to carry out some baseline assessments such as BP measurement, blood sugar measurements. Then the nurse will refer the patients back to the pharmacist to carry out in-depth medication assessment and also identify potential pharmaceutical care issues. So the pharmacist will suggest pharmaceutical care issues to the doctors. It is still up to the doctors whether they want to accept or reject the pharmaceutical care issues. Okay, so after that, the patients will go back to see the pharmacist again to collect their medications. And if required, the patients will be referred for dietitians for diet counseling and also diet adjustment. Okay, so I basically extracted several published studies from Malaysia that actually led by pharmacists. As you can see, HbA1c consistently reduced significantly, and in terms of medication-related behavior, consistently improving. So this basically underlining the impact of pharmacists in Malaysian setting as well. However, what I would like to draw your attention is, if you look at the study populations, it is still at the older age range. Very, very limited studies have actually looked into how we should empower, how we can help the young people with type 2 diabetes mellitus. Therefore, it seems to remain unmet needs even in diabetes self-management, education and support. So the theme of today's seminar, patient-centered. So when we talk about patient-centered, we need to take into considerations what the young people want. Okay? Apart from, of course, looking into what the young people want, we thought of it is also important not to just focus on the young people, which we have done, and I've shared earlier on, the needs and challenges of young people, right? We also need to explore what the healthcare professional think in terms of providing diabetes care on a daily basis for young people. So we talked to a total of 16 healthcare professionals in Malaysia from 2 hospital sites. Most of them actually have provided diabetes care for young people for about 5 years or so. So because we use maximal variation sampling, meaning we want to make sure that our participants come from different disciplines, so we ensure we recruit participants from different healthcare areas, including diabetes, nurse educator, occupational therapies, staff nurse, dietitian, pharmacist, etc., so that we can hear different perspectives of what they are doing in providing care for young people. So this is what we found. Yes, the healthcare professionals said that every day they experience challenging interactions with the young people. Some young people, because we are Asian, right? We tend to be a bit shy. We tend not to share our story, particularly with young people. So because probably they're afraid of judgmental thoughts and thinking from the healthcare professional. So that to the healthcare professional is very difficult, because if there's no communications, they have no idea what the patient is thinking, then it will be difficult to help them. Okay, so many of the young patients, they underrate the severity of the disease. They thought that they were still young. Why should they take medications? Why should they come for medical follow-up? No need. They don't experience any complication yet. They don't know why they need to come to see the doctor. And there are sometimes lack of social support, even from the family member, the parents, in denial stage. My child is so young, impossible that he will get type 2 diabetes. So that actually contributes to additional challenge to the healthcare professional. And limitations in healthcare budget. Perhaps, I'm not sure in Indonesia, in Malaysia, we have a quota system in the public healthcare system. So for this quota system, on a monthly basis, only this amount of patients that the healthcare professional can prescribe the medications to the patients. So they need to really manipulate how prioritize sometimes which type of patients that they could actually prescribe the medication, particularly, of course, the newer medication, more expensive medications, to the one that actually will benefit the most. And also, the healthcare professionals have used a variety of strategies in supporting patients in diabetes self-management. The most important themes that we have come across is building the rapport. Okay? So they said that it is important when you communicate with young people, you need to be friends with them. Okay? You need to build the relationship first. And then when planning diabetes care plan, we could not start too much. We have to start slow and then go bigger slowly. And threatening techniques were sometimes used, particularly for resistant patients. They sometimes use that one day you are going to die, but that's only reserved for patients who are really, really resistant. Okay? So they also provide some suggestions on how to improve diabetes care for young people, particularly in terms of the flow of knowledge transfer, because currently in DM Tech is still very physical, face-to-face, and the medication and the information is still a bit of paper printed basis. So they suggest that it would be better if we show videos or infographic which is more engaging and can attract young people. And they also emphasize that it's very, very important to establish a community-based support among the patients with type 2 diabetes, because, as I mentioned earlier, type 2 diabetes is largely patient-driven in terms of the management of the disease. So interestingly, recently, the investigators from our neighborhood country, Singapore, they have actually investigated using face-to-face interviews among patients to look into what are their preferences when coming to diabetes self-management and education support. As you can see here, some of the informations actually coincide with our research findings. And what interesting here that I've seen is in terms of the topic of interest. Now, the young people actually prefer information which is really very specific. They say that sometimes the healthcare professional give too general, too surface informations. You cut down this portion. So they don't feel it is helpful for them. They want more specific, more directive type of advice so that it will help them to choose what diet they can go for. And also, they would like to know age-specific diabetes complication. For instance, how the disease could affect fertility, how these medications would affect my fertility. Because young people, right, diagnosed with the disease at young age, many of them actually plan to have baby in the future. So this type of informations were generally not covered in most of the diabetes self-management educations. And over here, medications effects, this is where we can play our role. They want to know the drugs, medications of action, and also what type of side effects that they may come across in managing the disease. Otherwise, the young people, when they are in doubt of the efficacy of the medication, they will either stop the medication themselves or they will self-adjust the medications. So over here, that's where we can play a role in. So I would like to end with 4 important take-home messages for everyone to ponder and bring home. Number 1, diabetes self-management, particularly among the young people, is not just about whether they are taking medications or not. Their behavior is heavily influenced by multifactorial factors surrounding them, including intrapersonal, interpersonal, community, and even sometimes up to policy settings. Okay, so for managing diabetes mellitus, it actually involves a whole community to manage it. It's not just a matter of one person issues, it's actually a the surrounding of the individuals with diabetes mellitus. Patient-centered diabetes low bat already. Patient-centered diabetes cell management education support is necessary to help patients to sustain their daily basis in managing their disease. And finally, we all, pharmacists, can contribute in supporting the patients, particularly in medication-related issues. As you can see just now, one of the preferred topics that the young people want is medication-related issues, particularly on medications of action and also what kind of side effects that they need to encounter or embrace in managing their disease. So with that, I thank you very much for your attention, and I'm happy to have your thoughts in a short while.
Thank you, Dr. Ward, for your sharing. So the problem of facing young onset of diabetes or YOD is quite challenging, yeah, because we see nowadays young generation like us maybe have a bad habit of diet. Okay, who's in here already or like a sweet things or sweet coffee every day? Please your raise hand, higher. Siapa yang suka minum manis, makanan manis setiap hari mungkin? Okay, nah, it's proven. Oh, shy. Okay, Dr. Wong say that you shy. In Indonesia especially, maybe 80% population adolescent take their coffee or sweet things, sweet food and beverage every day in the reason of self-reward. Ya, in the reason of healing. Ya, sedikit-sedikit self-reward ya, makan enak, dessert manis. Who's agree with me? Who's agree with me? Siapa yang setuju? A lot of people agree with me about that. Oh, you too. Maybe when you on the way to the Stones or in Unmas, there are a lot of coffee shop in Bali today. So there are a bad habit of diet, intake too many sugar. But nowadays there are a lot of so many viral or hit sports like paddle, pilates, tennis, and marathon. Yeah, I think this phenomena. It's also type of fear of missing out, FOMO, but it's also the positive impact to the young generation to make sure they keep healthy unless they used to take a lot of sugar every day. Maybe that's the truth right now. Okay, thank you, Dr. Ward, for the insightful sharing and presentation. And for the next agenda is Q&A session. I'm informing you for the online participant who want to ask questions for both speakers. Please write down your question on the comment section, or you can asking directly with your raised hand first. And for the on-site participant, you also can ask the both speakers, please your hand first and mention your name before stating the question. So now, any questions so far for online and on-site participant? Okay, maybe while waiting the question for online and on-site participant, I would like to take this opportunity to pose a few questions for Bu Yunita and Dr. Wang. Maybe first from Bu Yunita. Bu Yunita, I've been worked in hospital maybe 3 years ago. I've been a coordinator in ambulatory pharmacy service, so I realized that doing communication and doing counseling to the high-risk patient, especially elderly, is so challenging. It took a lot of effort besides their incapability due to age, elderly also, condition, and maybe, as mentioned Dr. Wang before, there are a social judgment. There are social judgment about their condition, their psyches. So my question is, what is the challenge to implement patient-centered care in high-risk patient, especially in elderly? So in Indonesia, we know that elderly is lack of education, lack of technology access, so they far from updates of medication. This is for Bu Yunita. And for Dr. Wong, I a bit curious about the MTAC, so diabetes medication therapy adherence clinic, right? So the Malaysia is already implement the MTC that involve nurse, doctors, pharmacists, and dietitians. Was a great profession. And how has this program addressed to self-management, especially among younger patients? And has the DMTAC protocol has been implemented all over the healthcare facilities in Malaysia? Thank you.
Can I answer first? Okay, thank you. Bu Dian, our sweet moderators today. So, the question about the challenges for elderly patient in ambulatory care, it is actually related to a few factors, and one of it you already mentioned. They are not technologically savvy, so elderly people sometimes not very update in using mobile phone or like a reminder and everything. And as we know, to actually empower them, a lot of research has been done on the use of IT or telemedicine or using the application to actually improve medication adherence and how to remind them how to use medication. But then it can be difficult for elderly people. So as a pharmacist, we need to actually find out what is their problem. So if they are very comfortable of using printed paper, so we have to use it. So, or if they're okay with using a pill box, you can just give a pill box as a method to actually help them. And then they also have a tendency to forget everything, so we have to make sure that when we are doing patient education, we have to assess their understanding and it will be the best if we can provide information in written, so their family or their caregiver actually can also read and learn. So remember Mrs. Polly, the son doesn't know what is really happening, so he just asked the mother to actually just took everything, including the NSAID. So yeah, they have problem memorizing, and then they have problem maybe with IT, even though not everybody, but maybe most of them is like that. Maybe you experience when your mom asks you, gimana caranya masang alarm? Ada nggak yang ibunya seperti itu? Ya kan? One day we already told her how to do it, but then a few days later, when she wanna do it, then she asks again. So that is happening also with the medication. So yeah, the pharmacists need to pay attention to these elderly people, and the challenges is quite a lot. Yeah. Okay, thank you.
Okay, thank you. So the important one is team collaboration with the family of the patient, and make sure she or they understand what they have to do with the medication, what they have to do if they forgot the medication, and if what they have to do if they had a side effect of the medication. So maybe it's complicated, but I think it's will fulfill with the team collaboration and interdisciplinary, maybe like that, Bu Yunita. Okay, thank you. Please, Dr. Wang.
Okay, so regarding the diabetes medication therapy adherence clinic in Malaysia, so currently it is widely available in public hospitals. Private hospitals, it depends on whether they have diabetes educator or pharmacists to run the services. But I'm drawing the findings from presentations, most from public hospitals. They are the ones that contribute most in terms of the research findings. So whether it's available in whole Malaysia, some sort of yes and no. In public hospital, yes, we do have that, and also large primary care clinics, but those in rural areas, not so yet. So usually if the patients need to receive educational type of interventions like DMSES, they have to attend primary care clinics, the larger one, or they have to come to public hospitals within Malaysia. So the Ministry of Health is trying to expand this service into community pharmacy. During the COVID time, they tried to train community pharmacists to deliver MTech in community pharmacy setting. I was one of the participants as well. But the program, because it was sort of halted by the COVID-19, many of the things we have to bring online. So we attended the training mostly online, and then followed by, only recently we completed like 2 days of attachment at the selected hospital sites. So we have yet to see how this can be implemented in community pharmacy setting. But of course, the community pharmacists do provide some sort of counseling in terms of medications. But in terms of DSMES, it's really it require a structured type of program and continuous monitoring the patients, because it's a continuous support system. It needs to be continuously offered in order to help the patients to sustain their behavior. Otherwise, it will be a bit difficult. You will see the patient's blood sugar up, down, yeah? Okay, so in terms of whether the MTech address only for young patients, currently not, to my understanding. The DMTech in public hospital Malaysia, mostly they provide generally to all kinds of patients with diabetes mellitus, not really specifically for young patients. So that's why when we talk to the young patients, because the clinic is shared, right, among the older person and also the young person. So the young patients usually say that I hope there's a special clinic for them only, because sometimes they see the older person, they feel like they are like old people as well to get the disease. So that's what we saw from, what we get from the perspective of young patients when we carry out the research.
Okay, thank you, Dr. Wong. So it also implemented in public hospital in Malaysia, and it will have more, besides the release of the DMTAC protocol, the important one is the continuity and the consistency to follow up the medication for patients. Okay, we have a question in on-site participant. Are there any question for on-site participant? Okay, I will go to the online participant. We have one question from Surya. Okay, I will read the question. Hello, I'm Ayu Surya from Community Pharmacy. Interested to know from Ibu Nita, based on your experience, do you know what is the simple application for patient medical record to let the community pharmacists use to do patient monitoring?
Oh, thank you. So, Ibu
Surya. Ayu Surya.
Okay, thank you for the questions. So the question is, what is the simple application for patient medication record to be used in community pharmacy? In my opinion, the simplest one should be the one based on the electronic version, I mean in the computer, so not the hard copy one. But then the pharmacists need to buy it, spend some money, because we cannot just develop it by ourselves, or maybe if we can, then it will take some resources also. Most of pharmacy, the small one, I'm talking about the small independent pharmacy, not all of them has already used IT-based computerized patient medication records. Most of them usually still use the paper-based one that is not so easy to actually call. We cannot call, like for example, if it is an IT-based one, then we can just type and then maybe we put the ICD-10 or maybe put a category of a disease, then we can call a patient by a system. But if it is in hard paper one, it's not possible, and then we have to open so many file to actually, and it's easily got lost. We easily got lost to find which patient that we need to pay attention for. So yeah, the computer-based one will be the best, but I cannot give suggestion like which brand. So yeah, usually it is available out there, I mean for the hospital use and the clinic use, so the pharmacy can actually maybe adopt that for a fraction of price, because they don't use the medical record part, just using for the patient medication record for the pharmacy use only. Probably that would be the best. Yeah.
Okay, thank you, Dr. Bu Yunita. So the important one is technology based. Yeah.
It's different with the elderly patient. It is for pharmacists to be used. So I think pharmacists should be able to use technology. Yeah, maybe elderly pharmacists need times to actually try to adapt to that. But most pharmacists, I believe they will be able to use it.
Okay. In Bali especially, many hospital has implement medical record with electronic too, but as you mentioned before, the elderly practitioner like pharmacists, or if I have mentioned doctors, it used to be use a manual to assessment, to use SOAP. So the nurse have took a lot of effort to copy her manual or their manual to the system. So it may took time to integrate it, electronic medical records for all of the healthcare facilities. Maybe not in Bali, in Indonesia.
I think the hospital and the clinic have less problem because I think it is mandatory for them to use the electronic version of the system, right?
Yeah.
But the one in the community pharmacy, there is no regulation that actually push them to like harus punya sistem itu enggak ada. Jadi ya mungkin kalau chain pharmacy or the state-owned enterprise pharmacy owned by the government, it is pretty big and they already have their system developed. But the small individual pharmacy, it takes time for them maybe to actually keep up with the technology and the patient medication record use for improving patient safety.
Okay, thank you, Bu Yunita. And there's a question for Dr. Wong. I will read it from Ibu Ayu Surya too. For Dr. Wong, for diabetic patient in community pharmacies, can we adjust the dosage of medicine that the patient already taken because according to their laboratory research for HbA1c did not decrease for 3 months? Okay. He just take metformin 500 milligrams, and what should we suggest for it? Because according to historical lifestyle, he have good dietary and cholesterol on control by atorvastatin 20 milligrams. Please, Dr. Wong.
Okay, so whether you can adjust the medications for the patients at your setting, it really depends on whether you have been trained to do so. That's number one. If you have been trained to do so, of course, we are pharmacists, we are supposed to do, right? Even in hospital setting in Malaysia, the DM Tech pharmacists are the one that actually help the doctor to adjust the insulin dosage. But the background is that they are trained to do so. So in community settings, if you have been trained and certified to do so, I think there's no problem. But it's also important for me, I think, that you have a proper referral system in place, that if there's anything happen to these patients and it is time to refer these patients for medical follow-up, you should do so. So the referral system should be in place. Okay, so back to the whether they can adjust or not, depends whether you are trained to do so. If you are trained, I think it's okay. You should go ahead. That's what we do.
Actually, in Indonesia, there are unwritten policy. If we, as a pharmacist, modification or adjust the dosage, we have to call the practitioner, doctor, so we cannot adjust manually from the point of view of pharmacists. There are a lot of unwritten policy like that, maybe.
Yeah, actually similar in Malaysia at this point of time as well, because Malaysia, we don't have separations of dispensing, right? So if there's anything, we still need to refer back to the doctor. Yeah, but in hospital setting, because the DM Tech already work in a team with the endocrinologist, so the pharmacist can make suggestions in dosage adjustment. At the end, the doctor is still the one to endorse whether he or she would like to accept that suggestion or not. Yeah.
Okay, thank you. There are more questions from online participant. Good morning, I'm Ngurah Hadi. I would like to ask question to Dr. Nita and Dr. Wong. For Dr. Nita, I heard about the system that we record the medication that had been used. How can we as a pharmacist do to make a system that need record such a specific medication history that can use for the next event? And the question for Dr. Wong, I will ask about how we can educate the young people that born from family is in low economic situation, because we know sometimes people with low economic not consider good habit for daily, and they often forget to maintain good habit of health. Maybe not for young people also, but for the parents too. Oh, okay. Bu Yunita, I heard about the system that we record medication that had been used before in Indonesia. How can we, as a pharmacist, do to make system that need record such a specific medication history? Maybe for a communication or counseling to the patients. How to a pharmacist like us with the system, how we role of the pharmacist with the system to record a specific medication to the counseling to the patient from the patient medical record.
Okay, thank you. So the question is how we as a pharmacist make a record,
Make a system.
make a system.
Make a system that need record a patient history.
Oh, okay. So yeah, as I said before, if we need to use computer-based patient medication record, we have two choices. We can actually just maybe purchase the system from an outside vendor or whatever, and I believe there is a lot available, especially the one that have been used in the small clinics, not on the big hospital. That's maybe more feasible to be adopted for a pharmacy only. And then the second one is to develop by ourselves is still possible. I did that before. It was a long time ago, more than 10 years ago. I was the manager of the for pharmacy owned by the university, and then so we developed a system we called an IT people, and then we communicate with them, then we create a system to be used in our pharmacy. It is pretty tiring because we develop from scratch, and it is also I think more expensive rather than we just buy the available one. Yeah, it is possible to create from the scratch, but I did not actually expect that more people will do the same thing as us, because it'll be like time consuming. And then what happened with us, we have like 6 pharmacists working in the pharmacy, so we have lots of resources. So, and we were like picking up by the university also. So yeah, we do have the people, we do have the resources, we do have the time. So yeah, it's possible, but then maybe it'll be easier to find the one that is readily available in the market. But how to write? Is it the question is how to develop, or is it how to write?
How to record the specific medication for the next event.
For the next event. What we used to do is actually we write the medication that the patient have now. I mean the one that they got it now. For the future use, I think what we usually have is like a reminder system when it is the time for the patient to actually refill their medicine if they have a chronic diseases, like for example diabetes. So we can remind them that today is the time for you to actually come to our pharmacist and get your medication. In our system, the patient must come like every month. Yeah, it's a monthly visit to the doctor and to the pharmacy to obtain their medication, or maybe not to the pharmacy but to puskesmas. It depends. I think every region in Indonesia have a different setting. In some of the city, the patient can go to a pharmacy. So the pharmacy is linked with the primary healthcare center to actually manage their medication, the BPJS medication. But in other city, I know that the patient must go to the puskesmas, their primary healthcare center, and get the medication also from that puskesmas. So yeah, we can set up a system that can remind us to remind the patients, you know. So we make sure that the patient come to the primary healthcare center to actually visit the doctor and then obtain the medication. I think that's a way, because if it is like in future use, I think that's what I'm coming up to my mind. Okay.
Surely need technology ya, Bu Yunita ya. Okay, in Malay's hospital, the patient is actually receive the medication book especially for the chronic patient and especially for elderly. So in my last hospital, they receive the medication book. So when we dispense their medication, we stick the label of list of drugs in their book, with the name of patients and number of medical records and list of drugs and how to use it. So if they go to the hospital again the next month, I can see the history of the medication, and this is the type of how to monitor the medication use on patients. So it's the simple one, but it's actually manual.
Oh yeah, can I add a little bit more to that? That's a very good idea, that you print the label
of the drug list.
The drug list. Also you print maybe the apa yang kita sebut etiket gitu mungkin ya. Yeah. So they print them all together. So yeah, but I don't know whether it's common to do it in community pharmacy, not the big pharmacy one, but the small one. But it's a good idea that actually reduce the time of filling in the books. You know, because we have two type of patient medication record: the one that been kept in the pharmacy and the one that is in the form of a book that the patient can bring. Why? Because in Indonesia, patients tend to go to a different pharmacy. They are not like stick to one pharmacy only, so they can go to anywhere. So some of the pharmacy actually choose to create a patient medication record that is attached to the pharmacies, attached to the patient. So the patient have to bring that everywhere and then give it to the pharmacist, and the pharmacist will need to write down. But it took time. Yes. It's like time consuming to actually write it down. So if the pharmacy have a system that can print a label and then just stick it like the one in the hospital, that would be great.
Yeah, we call the book is buku sakti. In Malaysia, you know sakti, right? Okay, buku sakti. They also bring the buku sakti every they visit the healthcare pharmacist. Actually, I work in Surakarta before. They have a buku sakti for the patient, actually in chronic illness patients in Surakarta. Okay, maybe it's your turn, Dr. Wang.
Okay, so before I come to the questions, I thank Dian for the good idea just now, print the label. I think I will bring back to Malaysia and see how we can investigate these applications for Malaysian patients as well, which is a good idea. Okay, so coming to addressing low economic patients with low economic background, socio-economic background, that's really a tough question to address, I would say. I don't think this is an issue in Malaysia as well. As you can see from my presentation just now, we also have difficulties even in supporting patients with diabetes mellitus, because it involves, it's a chronic disease that involves continuous support. If we don't have cooperations from caregivers, we really in big issues. That's what brought up by healthcare professionals in Malaysian setting. So I think in my perspective, I don't have like structured or practical tips to offer, but I did learn something in the past 2 days during the ACCP conference. Prof. Truong, professor in public health, so he sort of provide this insight that when coming to helping patients with behavior change, the first thing is we should not be judgmental. We shouldn't be judgmental, and it's actually important to tell the right story. Now, we are dealing with patients with low social economic. So we must first meet their needs, basic needs. Some of them probably don't have consistent diet. So perhaps as a healthcare professionals, we could see how we can ensure they take their meals more consistently, for instance, in smaller portions, for instance. So after that, only we can sort of teach them how to exchange carbohydrate. If you take me today, this morning, perhaps you don't take kueh, for instance. So I would think that it's better to tackle their daily needs first, then only we move slowly to medication intake. So we need to build the rapport with them slowly, and then we move forward from there. That's what I think.
That's okay. So the important one maybe the empathy,
Yes,
right? The
that's
empathy to the person with low economic, social, and low economic condition, that we have to know their basic needs, basic concern of the healthcare, so we can relate our medication treatment or medication program to them.
Perfect.
Okay, thank you. Maybe I will give change to the on-site participant. Are there any questions from on-site participant? Okay, Mrs. Dara, the MC today. Please, Mrs. Dara.
Okay, thank you, Mrs. Dian. Maybe first of all, I'm sorry because I'm the master of ceremony, but I really want to ask one question, maybe one for Dr. Yunita and one for Dr. Wong. And the first question for Dr. Yunita Nita. So in Indonesia, maybe I will move first. Because it's quite noisy here. So for Dr. Yunita Nita, we know that in Indonesia, people usually use like herbal remedies, like a plant-based traditional infusion or something like that, along with their primary medication. And sometimes they consider it as the basic diet. But actually, I think herbal remedies or something like that is actually also interfere the primary medication. But when we try to gather the information about related to their medication, sometimes they do not disclose that information. Why? Because they think it's the part of their diet, not as the part of medication. I would like to ask, how do we comprehensively gather that information? Because I think that herbal remedies is very, very interfere the primary medication, and I think that also need to be gathered comprehensively, and how we can gather that information without any judgmental condition for the patient and for the people. And do you think that vocational staff like tenaga vokasi can also take the part in this information gathering in the community? And for Dr. Wong, I think it's quite challenging to face the teenager right now, and especially because I'm not from the Gen Z, and we know that Gen Z it's quite challenging to face with their unique characteristic like tech-savvy, critical, or maybe like very bond to the community, especially in the social media. And I would like to ask, how can we take advantage from that characteristic to maybe improve the adherence in medication? Maybe that's all from me. Thank you, Ms. Dian.
Thank you, Mrs. Asadara, for the question. Maybe Bu Yunita first.
Thank you for the question. So basically the question is, how do we gather information about herbal remedy? Because herbal remedy, as we know, or traditional medicine, as we know, probably can interfere with the medication that the patient use or have interaction with the medication. For a start, it is already a very good thing that you actually acknowledge that the herbal remedy is a very important part that we do need to dig from the patients. That's the very first thing that it is needed, because not all pharmacists remember about this habit of Indonesian people to take jamu, to take infusion, or the daily drink that is actually part of the Indonesian heritage. So yeah, the first thing is to actually remember that, and then after that we try to actually talk to the patient to get some information. Why I said that, when we interview patient and then we ask question like, what drug did you take at home? So she or he will only say the drug. The drug means the modern medicine in form of oral form. Even the medicine that is taken by other route, even though it's a medicine, sometimes patient did not mention because she didn't really think that as a medication. Because some people, kalau kita bertanya dalam bahasa Indonesia, ibu di rumah minum obat apa? Then they will disclose, they will give information about obat yang diminum. Padahal mungkin mereka punya obat lain yang tidak diminum orally, but they took it like maybe a cream, maybe like something to be used, maybe inhaler, or maybe some other dosage form. So yeah, when we ask question, we have to ask question clearly, and then we have to actually use different probe. If when we say, apakah ada obat yang diminum di rumah, Bu? Setelah si ibu menjawab, then you can add other questions. For example, do you also take any vitamin, multivitamin, or do you have any jamu, or do you maybe regularly drink something that is for your health? Karena ada banyak vitamin, suplemen, kemudian minuman yang dilarutkan yang sebetulnya adalah bagian dari untuk menjaga kesehatan. Yeah, for example, my mom have a knee problem, yeah, and then she used to drink something in a long sachet, kayak saset panjang itu yang diaduk, yang untuk sebetulnya untuk mungkin ada gelatin apa dan lain sebagainya. When we ask that question to the patient, they don't actually associate it what they drink and what they took as a medicine. So yeah, it's correct that we do have to probe the question accordingly. Jadi mungkin dimulai dengan bertanya obat apa yang diminum, atau ada obat lain yang digunakan. Kalau kita menggunakan kata digunakan atau dipakai selain yang diminum, biasanya mereka akan cerita, atau lanjutnya adalah ada suplemen kah, ataukah ada vitamin kah, ataukah ada yang lain-lain buat keluhannya, ibu nggak ada keluhan lain, oh ya lutut saya sakit, oh ya kalau gitu buat lututnya apa bu? So it is helpful if we actually know what is their problem, and then if we have like preconceived idea like what kind of thing that the patient usually use, so it is good. One time there is a patient who come with vomiting problem, okay, so we try to ask him, it's actually my senior lecturer at the time, muntah-muntah gitu, terus ya kita tanya, kenapa muntahnya Pak? Iya saya kebanyakan minum rebusan daun apa itu, saya lupa daun apa. Terus saya, so what is that rebusan actually for? Untuk ini mengeluarkan dahak. So it's actually I think expectorant. So to mengeluarkan dahak gitu ya. But because he took it like excessively, kebanyakan biar cepat sembuh, yang ada malah jadi muntah. So it is like quite surprising to us because we never thought that our patient will experience adverse drug reaction. Not adverse drug reaction, it's not a normal dose, so it is adverse drug event because of ramuan itu tadi. Jadi ya memang the key is one, you ask clearly and then we try to ask with a different type of words. We change the words to find it. Usually we do have a feeling that I think there's something more, so then we keep asking. Ya kayak kalau Gen Z bilang kepo banget gitu. Ya tapi harus seperti itu. I hope that's clear.
Thank you. Bu Yunita, please Dr. Wong.
Okay, perhaps I add on Dr. Yunita as well. In Malaysia, sometimes we also ask the particularly older adults, they tend to self-medicate. So we sometimes ask them, are you using any medication that you buy from pharmacy, or any supplements or any herbal products? We ask multiple different type of questions to to clarify the most complete medication list that the patient is taking. But generally in Malaysia, the patient seems to be quite okay with pharmacies. They tend to be a bit honest. They tend to share their hearts, meluahkan hati dia kat pharmacy. Compared to doctors, they are a bit afraid of doctors. When doctors ask them, are you taking any other medications? They say no. When they come to pharmacy, yes, I'm taking this. We have encountered that personally. So we thought of we pharmacists are a bit more kind-hearted, so the patients tend to approach us more compared to the doctors. That's side comments on top of that. Okay, so regarding on how we should approach the young people in terms of supporting their diabetes self-management. So currently in Malaysia, as I mentioned earlier on, is still very much face-to-face. I believe that there are some pharmacists who have started using some apps, some digital tools, but the MC has actually brought in an important tools that we can perhaps leverage on is social media, internet, and now AI. So our team is currently also would need to investigate a bit more on how these internet tools, Internet of Things, AIs, in helping the healthcare professional and older adults in Malaysia setting. So we welcome as well collaborators for Indonesia who actually have experience in building the digital system to work with us. Perhaps we can learn from you as well, and also helping the patients, young patients back in Malaysia. But I think, yes, we do need to leverage on social medias, internet, and coming up AIs to help the young patients. Because now even my niece who are younger, the new gen, they don't tend to talk to us, they tend to WhatsApp us. They don't talk to us face to face, but they WhatsApp us, they post in social medias. So I think we should actually leverage on that platform to help the young patients for disease management. Yeah.
So involve the social media, right? So basically the young generation, especially Gen Z, all those participants actually is Gen Z. all these participants in here actually Gen Z, they always have a big trust, a big belief in Chat GPT, ya. Setiap buat tugas buka Chat GPT, betul? Betul. Kita sudah tahu itu semua, ya. They have a big trust in Chat GPT, in TikTok, in Instagram, in YouTube and other social media. So maybe if we want to educate young generation, especially Gen Z, we also have involved media social, we have also involved AI and so on. So they can more relatable and they can more educate and they can more know the importance of healthcare facilities and healthcare diabetes management.
Yeah, agree. So I do hope that I have a young heart, but I am beyond the education system because currently I sometimes really impressed by my students. They can edit videos, they can put up videos which is very engaging, that's very powerful. So I think perhaps we can work with the young one as well to engage the young ones so that they can talk similar language. So thanks for giving the good ideas again.
Okay, thank you. And use public figure too. Public figures have more important crucial role to educate young generation today because young generation actually more believe in public figure than their parents.
Yeah, true. The peers. We need to look in the peers.
Okay, thank you, Bu Yunita, Dr. War, for insightful discussion, fruitful thoughts, and we have a lot of knowledge today. But we have time limitation because we have to move to the next session with Prof. Said as the speaker. So maybe I would like to read the conclusion of this first session. The first session is about patient-centered care, especially in high-risk patient and young onset diabetes. So this one, we as a pharmacist, we as a student of pharmacists have a crucial and critical role in ensure the medication safety to all the patient with team collaboration, good protocol like the DMTAC, okay? And also we have to follow up the patient to ensure the understanding of the patient, to make sure the continuity of medication use and ensure the medication safety. Maybe you both have a take-home message or closing statement to the topic, Bu Yunita or Dr. Wong?
So one key important things that I would like to mention is we do have a role as a pharmacist. We do have a role. So yeah, we need to maximize our role in the patients, especially the high-risk patient. I think that's my last message. Thank you.
Thank you. Aina tiru Dr. Yunita message juga. So we do have a role, we all pharmacists, particularly the younger pharmacists, you have the role to empower your peers, particularly those who suffer type 2 diabetes. You can help them in sustaining their daily diabetes self-management. Thank you.
Okay, thank you, Bu Yunita. Thank you, Dr. Wong, for the closing statement. And ladies and gentlemen, now we came to the end of first session. I would like to extend my gratitude to the speakers for the insightful knowledge, sharing discussion, and sharing thought. I also thank to the all audience, on-site and online participant who have for the active participation. Now I will give back the session to Mrs. Sasadara. Thank you.
Thank you, Ms. Dian. Let's give a big applause. Okay, for our outstanding speakers, thank you, Dr. Yunita, thank you, Dr. Wong, and thank you for your very insightful presentations, and for Bu Dian, Ms. Dian, for skillfully guiding us here. in our discussion session. And to express our gratitude, we will now present certificates to our speakers and moderator. May we kindly invite the Dean to the stage to present the certificate. Okay, thank you one more time. You may now be seated. Ladies and gentlemen, we will now proceed to the second session of our seminar. This session will be guided by Apoteker Nyoman Budiarta Siada, S.Pharm, M.Pharm, an experienced academic dedicated to advancing pharmaceutical care. We kindly invite Mr. Budiarta Siada to take your place on stage. Okay, how are you today, Mr. Budiarta? So Mr. Budiarta is usually called Pak Komang Budi.
Yeah,
how are you today?
A little bit nervous.
A little bit nervous.
Because this is my first time as a
This is your
moderator.
first time. And this will give you a big experience, right? Okay. So, Mr. Budiarta, before we start this session, please allow me to introduce yourself first. So, Mr. Apoteker Nyoman Budiarta Siada, S.Pharm, M.Pharm, is also a lecturer at the Department of Pharmacology and Clinical Pharmacy, Faculty of Farmasi, Universitas Mahasaraswati, Denpasar. He earned his bachelor's, professionals, and master degree in pharmacy from Universitas Surabaya. Mr. Budiarta Siada has been actively conducting research in the field of pharmaceutical care. So without any further ado, Mr. Budiarta Siada, the floor is yours.
Okay, thank you, MC, for the time that you gave to me. Okay, dear participant, it's a pleasure to have been here with you, all of you guys. Okay. Yeah. In this seminar, allow me to introduce myself. My name is Nyoman Budiarta Syada. It is an honor to me to have been appointed as a moderator in this session, in this seminar today. So, without further ado, I'm pleased to welcome our distinguished speaker, Professor Dr. Syed Azhar Syed Sulaiman. So, dear participants, please join me in extending warm applause to our final speaker today. Okay, good afternoon. Yeah, it's a pleasure to have you here, Prof. So, we are deeply grateful to have you here in this event. So, dear participant, before we commence this presentation, so allow me to introduce our final speaker here. Organizing committee, maybe please display the PowerPoint. Thank you. Thank you. Okay. Okay. It may take forever to read this because this is too much achievement that Prof said achieve. Okay. Professor Dr. Azhar Syed Sulaiman obtained his bachelor degree in pharmacy from Universitas Science Malaysia, and later pursued his doctoral degree in clinical pharmacy in Michigan, USA. He became lecturer at School of Pharmaceutical Science, USM, in Kubang Kerian, and became deputy dean and the dean for the school. He was also the former director of Advanced Medical and Dental Institute in USM Penang. He has been as international figure for clinical pharmacy and halal pharmaceutical and cosmetics, been invited as keynote speaker and invited professor in more than 40 universities around the world and locally in Malaysia. He is currently the co-chairman in International Halal Ecosystem Conference in Paris, in conjunction with Olympic Games. And also the country chairman for Asian Clinical Pharmacy Organization, the Halal Committee for Malaysia, Malaysia representative for Halal Education Program for OIC at global level and expert in diabetes, osteoporosis, and infectious disease, where he worked closely with various world level organizations, including WHO, as we know as WHO, and working closely with various integrative medicine and male message experts around the world. He was the short-term WHO consultant in clinical pharmacy that have contributed to changing pharmacy syllabus in some countries like Mongolia, Philippines, Indonesia, and few others. And then he has received various awards around the world and locally, namely as the most excellent pharmacy educator, Isidate Award, and currently the only Malaysian that was endowed with such prestigious award at FAPA event, Most Prominent Pharmacy Educators Award by ASEAN Pacific Clinical Pharmacy Organization, and Leadership Award, the Most Excellent Pharmacist Award by Malaysian Pharmaceutical Society, award by Sudan Ministry of Health, award by Ministry of Health Saudi Arabia, and numerous other awards from national and international bodies, especially in clinical pharmacy and halal pharmaceutical. He has been invited to various countries around the world, including Africa continent, Middle East, USA, Asia Pacific region, and many third world countries to develop clinical pharmacy curriculum and developing clinical pharmacy services in their respective country. He represented Malaysia for OIC Halal Pharmaceutical Education Congress in Islamabad and World Halal Summit in Istanbul, Turkey, where he proposed the Halal Pharmaceutical Bachelor's degree syllabus to be used by Muslim countries around the world. Okay. Wow. So much achievement. Okay, let's conclude the introduction. So, the upcoming session, Prof. Syed will enlighten us on the topic problems and solution in information gathering during medication reconciliation to support patient-centered care. So, Prof. Syed, are you ready for commence the presentation? Okay, you have around 60 minutes. Okay, the time and stage are yours, Prof.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Om Swastiastu. Rahing Jing Sameng. I hope I pronounced it right. And before I start, I would like to thank Mr. Moderator for introducing me. And I would like to take this opportunity to really thank the organizer for having me here. This is not my first time in Bali, but the first time in this university. And it's I felt honored to be here together with our colleague, the former speakers, to discuss about this situation just now. And just before I start, actually, the information that was given just now, I just would like to add a little bit about it. Yesterday, we launched a digital health in Malaysia. It just being launched yesterday, and those are the incorporated things together with the platform to add in all the information regarding the information for all the things that related to the situation. So Alhamdulillah has been there, So here today, we are looking at the barriers that we have. My title will be The Barriers and Solution in Information, Gathering the Medication, Reconciliation, and also to support patient-centered care. So how many of you here is working? Most of you are students, right? Most of you are students. Anyone here from hospital, base? Online probably. Okay. So for those who has been working, I mean, you will be facing the same problem that mentioned by our colleague just now, and I'll be coming out with few of other issues that will be coming up. Next slide, please. Next slide, please. Next slide. Next slide. Okay. Probably I have few things to really impress myself here, to highlight the critical role of the MREC, that is medication reconciliation. We'll try to identify some of the common barriers to effective MREC and proven a solution that can be shared together, and also emphasize the pharmacist leadership when we are talking about medication or medicine reconciliation. Okay, anyone in this room know dari mana asalnya perkataan reconciliation ini? Ada yang tahu nggak? Ada yang tahu nggak? Belum tahu. Ya, sebenarnya dia berasal dari Latin, ya, reconciliate, yang bermaksud to bring together, memberikan sesuatu yang bersama-sama, dan dia bisa memperbaiki harmoni situasi dan juga memperbetulkan situasi di mana sebarang kemudaratan yang mungkin berlaku itu diberikan kebagusan untuk dalam kasus kita ini adalah untuk pasien, ya. Jadi di situ kita coba memperlihatkan bagaimana kita dapat memberikan yang terbaik, terutama all of you are the pharmacists, and how we can lead to that situation so that we can come up with the leading in terms of getting a better healthcare and health outcomes for our patients. Next slide, please. Next slide, please. Okay, so the definition, when we are talking about the medication reconciliation, we are talking about the systemic, the patient-centered, and also we are dealing with the process with an accurate list. Okay, we are talking about medication that taken by the patient. Just now we did inform about patient who are taking some of the herbs. You know, it could be OTC product for all we know, and compare against to the new medication. Artinya di sini ada, kalau si pesakit itu masuk ke hospital, diberikan satu obat yang baru untuk diminum, and we do not take account what is the medication that the patient has been taking before. You're going to see that duplikasi mungkin berlaku, interaksi mungkin berlaku, dan ini akan menyulitkan situasi lagi, ya. Saya masih ingat satu pasien, ya, dia mengalami congestive heart failure. Okay. She is on few medication for her congestive heart failure, but she is the one who is very compliant to the medication. Dia sangat bagus in terms of compliance. Tetapi one day the doctor gave her medication of a different trade name. So she thought this might not be a good medication. So she went to another the private clinic, and she get the usual brand name of that particular drugs, and she took everything, including the one that the doctor has been prescribed. So she is taking doubling. So for many days, the neighbor did not see or found her around the house. Mungkin mereka mengatakan mungkin beliau sakit karena beliau tinggal sendirian di rumah bersama beberapa ekor kucing. And after few days, everybody was so worried that she's not around. Usually dia keluar untuk menyiram pohon bunganya di sekitar rumahnya. Tetapi seperti udah 4 hari atau 5 hari itu enggak ada. Jadi dipanggil Pak polisi dan sebagainya, dipecahkan pintu rumahnya, ternyata dia mengalami partially conscious, enggak sedarkan dirinya separuh, ya, dengan najis kucingnya di sekeliling badannya karena beliau tidak bisa bergerak, dan dibawa ke hospital dan didapati bahawa the digoxin level for that particular patient was really very high. It's out of the therapeutic range. Kenapa? Karena beliau juga mengambil ubat yang diberikan di hospital dan juga ubat yang diambil daripada klinik, tidak mengetahui bahawa dua-dua obat ini adalah mempunyai kandungan yang sama. Walaupun trade name ataupun jenamanya adalah berbeza. Jadi itu yang kita harus tekankan, bagaimana pentingnya situasi untuk identify, you will resolve any discrepancies and also prevent any errors. And this is very important because as a pharmacist we want to see a patient who are without all those situations. Okay, these are the key steps in MedRare. If you look at some of the other journals, you may come up with slightly different, but this is WHO recommendation where the first step is verification. Ini sangat penting, ya. Apabila kita melakukan verification, kita harus sadar bahawa kita sebenarnya mendapatkan maklumat yang tepat. You need to get a very concise information from your patient. If the patient said, I'm taking 3 medication, one for my congestive heart failure, one from cholesterol, and the other one for my diabetic, make sure it is correct accordingly. It's not just like, I think it is for diabetic. You know, it makes difference there. So you're going to see that verification is very important. And it is very important for all of us as a pharmacist to get a complete history on medication for that particular situation. You have to get it all. Sepertinya katanya tadi, ya, kita mengatakan bahawa perlunya ngecek sama pasien kita sama ada mereka mengambil jamu atau mengambil sebarang suplemen dan sebagainya. So this is something that you need to see. Say for example, there are some bahan-bahan alami that will interact very much together with the other medicine. Misalnya jus mengkudu, ya. Jus mengkudu akan menghasilkan pendarahan ataupun boleh menghasilkan interaksi dengan warfarin. Misalnya, kalau pasien itu mengambil warfarin dan akan menjalani surgery in few days, you cannot take jus mengkudu together because it will cause bleeding during the operation. So this is very important for all of us to know, especially pharmacists, when you are doing the collecting the information regarding the medication history. These are some of the information that you need to know. Second one is clarification, whether this is appropriate. I come across a patient who have accident like 10 years ago, who was still on, at that point, was on ranitidine, and still continue until that particular day, which is about 10 years ago. Okay, and when we asked, all she said is that every time I came, my medication is being refilled and I'm using ranitidine. So we contacted the physician to ask, why was this patient on ranitidine? Because on her history, it was only motor vehicle accident at that point 10 years ago, and it was used by the medication was used then, you know. So after reviewing all these medication, it seems that the patient do not need ranitidine no more. You know, it should has been discontinued 10 years ago. So this is something that we need to really look at and review again. So we resolve any differences between the old and the new drugs. Whether, say for example, the patient is seeing a new cardiologist, you know, because she is having some problem with her cardiac problem, and this cardiologist gave this particular new drugs. So you have to ensure, we have to ensure that the new drugs that has been taking is not a sort like duplication of what the patient has been taking, or should there be interaction between these particular new drugs with the current existing drugs, so that we don't want to see any potential condition that may affect the patient. And documentation is very important. Everybody is talking about electronic health record. So inshallah, coming very, very soon, the first ASEAN digital health telepharmacy school will be established in Malaysia very soon, which is all of us will be coming in, and I'm also a part of those program. So probably kita gabung, yeah, inshallah. Okay, so you can see that it is very important to take the EHR, very, very important. Not all hospitals have it, but in some hospital, big hospital, probably in big city like Jakarta and so on, probably they might have. Okay, some of our like Selayang and so on has been using all those things. But again, we need to review all those situations accordingly. And this is me at the site of our hospital in Pusat Perubatan Bertam USM. All right, so why is this important? We have been talking from ACCP to this international seminar on patient-centered care. If you realize what we are talking about is the potential and also the good potential role of pharmacists to help and improve the situation of patients' outcome. So here we are talking about patient safety, definitely, and this is being WHO and so on has been talking about it, so that 50%, if you look at it, medication errors occurs during the transition. The patient is being discharged from ICU to the, say, another ward. You can see there's a lot of problem, if you do not really look into that situation. And of course, we can change or reduce the any cause of the adverse drug event at that point. The second one, the clinical outcome. You have to remember, when we give something, you are expect to get the clinical outcome. Say, for example, a patient is on antibiotic for some infectious condition. If your patient is not responding within 24 hours after giving the proper antibiotic with the proper dose for that particular situation, and the patient is not responding, so you will know that there must be some problem somewhere. Either the patient is having a resistance toward the antibiotic given, or the patient might be having interaction with another drugs that the patient is on at this point, or probably the dose is not sufficient enough. And one more important thing, which is very lacking among us pharmacists, is that we do not check the pharmacokinetic, pharmacodynamic interaction with that particular situation. You need to be reminded yourself that the changes of pH at the site of infection will change the penetration of the drugs or antibiotic to the site of infection, causing it to be not effective. It's not because of the drug is not effective, but the surrounding changes of the pharmacodynamic and also pharmacokinetic due to the changes of Cmax, changes of the volume of distribution and T-half will lead to a situation where it seems like the drug or the antibiotic given to your patient is not working. The truth is, it is working, but you did not realize that, say for example, nanah di bahagian luka pasien itu yang menyebabkan berlakunya perubahan pH menghasilkan penetration gentamicin misalnya ke arah itu tidak menembusi keadaan itu. Gentamicin need to have oxygen transportation, is active transportation. Di bahagian nanah itu tidak terdapat oxygen transportation, so penetration is going to be very less, leading to therapeutic failure. So kita sebagai pharmacist harus sadar situasi untuk therapeutic or pharmacokinetic dan juga perubahan-perubahan pH dan sebagainya. Dan financial benefit, a lot of publication is already being shown that by having this situation, looking at this, we will see a fewer admission to the hospital, fewer adverse drug reaction or even side effect, and fewer interaction and so on. That will cost us lesser burden on the total cost of treating for that particular patient. So what is our critical role in the MRAD? Yeah? We will see that during admission, most of us, or some of us, if not all, did not ask full question, just like what our speakers have mentioned. You might ask what medication you might take and so on. They might give a big things that they have. Well, I have diabetes, I have cardiovascular, I have renal. But did you know, satu kajian di Malaysia kemarin baru disiarkan, 37 hingga 38% daripada orang ramai tidak mengetahui bahawa mereka mempunyai high cholesterol. They don't know. They don't know whether they are having high cholesterol or not. Why? Kerana enggak pernah ngecek ke hospital, enggak ada simptomnya. Kenapa harus saya pergi ke hospital kalau saya enggak sakit? But the key point is almost 40% of the population have high cholesterol. So this is very dangerous. I mean, you don't want to get somebody get a heart attack. Then only you're going to be doing or treating the patient accordingly. So it is very important to get the best possible medication history. We call it BPMH, with the verifying from pharmacies, and you review all the records per se and focus on the patient who have a lot of drugs, a lot of medication. Usually patient who have more than 5-6 medication with them, it is going to be a lot of problems, especially untuk yang pasien yang lansia yang probably have a number of issues together with them. Okay, and during the hospitalization, you need to correct the dose accordingly. Say for example, we have an issue of patient who was given a drip of phenytoin, and suddenly we realize that the patient who do not have hypertension suddenly having hypotension. What was the issue there? So is the rate of the infusion of the phenytoin that was given by perawat melebihi 50 mg per minute yang bisa menghasilkan turunnya tekanan darah di situ. So you need to be alert about the situation. If your patient is having problem with volume of distribution in the body, then you will need to really reassess the situation accordingly. So this is important to collaborate. You need to discuss and talk with the physician, talk together with the other healthcare providers that taking care of that particular patient. At discharge, ramai di antara kita bila discharge itu cuma memberikan apa yang ditulis oleh Pak Doktor. You don't really ask whether this is necessary. Okay, there are points when I was doing many years ago, you were not born yet, looking at the prescription of the patient, and I was asking her whether she is having seizure. You know, how frequent do you have seizure? Because she was on a number of seizure medication, and she was said, seizure? I don't have seizure. So at that point, I realized there is something wrong somewhere. It turned out to be a mixing of patient's name on a prescription. Luckily, we didn't just give it to her and say, okay, you take these 2 tablets 3 times per day, 1 tablet once a day and whatever. We asked the patient first. And she was really very scared. Do I have seizure? You know what I mean? Kok saya datang ini kerana telinga saya yang sakit. Tapi kenapa tiba-tiba ada ini ya, ada, kalau di sini panggil ayan ya. Seizure, ayan ya. Kejang. Okay. Kenapa saya ada kejang-kejang ini? Itu aneh. I don't have seizure. Why do you ask me whether I have seizure? So when we check again, it turned out to be there's some problem from the clinic that the name is almost the same, but was dealing with wrong or different medication to be given to the patient. And this is very important role for pharmacists to clarify, verify, and so on. So, and here you need to teach the patient. It's very important for you need to educate the patient. The patient might think for giving anti-cholesterol, whatever, simvastatin, rovastatin, whatever, the cholesterol is going to drop tomorrow. You know? No. It will take months before it's really down. And you cannot just say, oh ya nggak apa-apa saya minum obatnya hari ini, besoknya rasanya udah aman, itu nggak perlu lagi. You have to remember the role of pharmacokinetic. Once you take the drugs, they will be going up. But once you did not take the drugs, the concentration going to go down again, and you start all over again from a different day. Karena itu, kita harus memberitahu ibu ataupun bapa patient kita, kenapa perlu diambil setiap hari obat ini. It's very important. You might think you are fine, but actually you are not. You know, kalau kita bisa lihat jantungnya transparent ya, semua ya ampun jantungnya kok kayak gini ya, ada kolesterol banyak ini. Aduh. Then you know what to do. But we have to tell them why they have to take it every day, why the dosage is twice per day. You know, I have diabetic clinic, as mentioned by my colleague, myself and few of the other physician and also nurses and dietitian was the first one who create Apotek in Malaysia. We are doing diabetic counseling clinic at that point. We call it diabetic counseling then, before the Apotek, you know. Our patient is lacking of information, and our patients are all from medium to low income. You know, we have janitors, we have sweepers, we have canteen helpers who came to my clinic. They are starting with hemoglobin A1C above 7, above 8. There was somebody who have 12, even very high. You know, but at the end of the day, when we educate them, when we do the education, they realize that the role of taking care of themselves is not us or doctors, it's them. Karena itu pada hari sambutan diabetik sedunia, pasien-pasien yang selama 1 tahun bisa mendapatkan hemoglobin A1C-nya itu between 4 to 6% will be giving sigil. Kita berikan satu sertifikat untuk semua pasien itu, dan itu dilakukan di Dewan Besar di USM, di Dewan, kalau kita Dewan Budaya dan juga di TSP. We give them, dan Presiden Diabetes Malaysia datang untuk memberikan CJ itu kepada setiap patient. Dan patient saya itu kan mereka kan janitor, itu kan merekanya tukang sapu. Kali pertama bertanya, nggak tahu mereka obatnya apa namanya. Tetapi setelah 1 tahun, everybody can talk Very well. Oh, I'm on metformin. Oh, saya metformin 500 mg berapa kali satu hari. Bisa berbicara begitu. Itu pasien tu. Itu is where the education plays a very good role. Dan mereka juga akan rasa bersalah kalau ketemu saya di kantin dan makannya kayak gini. Sebentar nak akan dinelpon. Malam nanti saya enggak ambil nasi, Pak. Jangan risau. Meaning, they are really conscious about the situation. And definitely, our role in MREC is systemic leadership, where we develop standardized MREC, we review admission, advocate for technology, and this is very important, and also alert for the high-risk MAC, example opiate or warfarin that the patient might be on. These are examples of the publication that myself and my team have done, and also some of the other colleagues around the world that have published regarding the MREC. Yeah? Recently, this one is regarding the medication impact of knowledge. This is my student, PhD student, together with me and another colleague that are dealing with MREC, and this was just published few weeks ago. Okay, and we have the impact of the elderly Jordanian in terms of MREC and so on. So all these are pharmacist-based information. Okay, what is it mean to say is that kita sebagai apoteker ini sangat perannya sangat diperlukan untuk melihat agar situasinya lebih bagus, ya. Dan ini juga beberapa preskripsi yang diadakan di awal tahun ini. Saya bersama teman-teman dari UI publish looking at the potential nephrotoxic prescription, yang kelihatannya apabila pasien itu masuk banyak discrepancy-nya in term of what the patient has been taken before and what the patient will be taking again. There's a lot of duplication, there's a lot of interaction that was found here. And this is also some of the other papers that we published together in regarding the MREC. Okay, and di dalam clinical case buku yang kita terbitkan bersama-sama dengan ketika itu di Arab Saudi dan juga di Dubai, we published a number of cases regarding medication safety for population case geriatric, ya, untuk lansia, dan juga effectiveness looking at the pharmacist lab medication reconciliation, melihat kepada medication errors in the hospital. So this is all the things that you have to be dealing with. Just remember, if you do things, you don't publish, nobody knows what you are doing. Okay? Kita harus memberikan gambaran bahwa apa yang kita lakukan itu sebenarnya bisa menghasilkan untuk kebaikan, bukan untuk diri kita aja, grup kita aja, tapi untuk seluruh dunia. Okay, you have to publish, you have to show the world that what you have been doing. Okay, this is another pharmacist rounding that reduce the preventable ADE in general hospital, and there are also another a lot of things that being used or done by pharmacists to review and a better MREC at the end of the day. Okay, so the key point is, when we are looking at this per se, the definition, a very easy one, is to create one accurate medicine list cross-transition to prevent errors. Artinya, pasien dari outpatient going to ICU, after ICU going to the medical ward, all the transition need to be done, need to be looked at very clearly, verify all the information accordingly. So that is what a MedRec is all about, in a very short, concise one. Why it matters? Because it's prevent the harm, save the cost, and this is required by regulators. In Malaysia, it is a compulsory to do that. Okay? Pharmacist's role, we are detective. I don't like to say detective, but that is where it is. We are looking at which loopholes where that might cause us problem. Okay, to me personally, I will say we are collaborators rather than detective. Okay, we are together with physician, dietitian, and all, and we are looking at we are the educators and we are the system innovators, because just like Dr. Yunita tadi mention tentang bagaimana untuk melakukan EHR, elektronik, untuk memasukkan informasi-informasinya. InsyaAllah mungkin kalau semuanya berjalan lancar, dibeli aja dari kita ya. Nanti kita ada negosiasinya. Alright, so here is the role. Okay, so sekarang artinya kita banyak mendengar ya. Ada kalian yang pergi ke ICCP kemarin? Ada beberapa saja. Okay, you have listened, you have looked, you have learned, but at the end of the day, you just ignore. My point is, you walk the talk. Okay, apa yang kita belajar, apa yang kita lakukan itu, kita seharusnya menjalankan tugas kita sebagai apoteker ya. So you walk the talk, you need to you are the pin between the bridges between all other healthcare. Advocate your seat for admission, discharge, and your expertise save a lot of life. Artinya di sini kepakaran anda, skill anda itu bisa membantu satu nyawa sekiranya mengalami sebarang keadaan yang boleh memudaratkan. Ini adalah kami dengan pesakit diabetes di Bethesda Hospital yang meneliti some of the potential MRAC di situ. Okay. So sekarang kita lihat secara general. Informasi ini didapati daripada publication and so on, dan berita-berita yang ada di online, dan melihat di situasinya. Mungkin the current status di Indonesia itu sekarang sudah emerge as a practicing ya. Is not yet widely standardized, belum lagi digunakan secara standard yang lebar untuk semua hospital, but is gaining attention. Artinya di sini sudah ada orang ataupun bagian-bagian hospital di seluruh negara di Indonesia ini sudah mulai memahami keperluan dan kepentingan MRAC ini ya. Dan this is being regulated by regulatory network in the Indonesia, dan is by CAS dan juga SNARS, iaitu Hospital Accreditation Standard is there, and you need to look at a number of Indonesian safety goals for the accurate medication documentation and so on. Saya ingat lagi waktu sebelum COVID itu, saya dipanggil di Jakarta untuk meneliti tentang documentation for patient, for pharmaceutical care and so on at that point sebelum COVID. Ya. Dan sekarang kalian sudah melakukan sesuatu yang lebih baik lagi. Dan ini adalah antara contoh-contoh yang dilakukan implementation of MRAC di Indonesia ya. Hospital Dr. Sarjito di mana dilakukan pilot MRAC program for high risk patient. Mungkin apa yang diperkatakan oleh Bu Yunita tadi sangat cocok dengan situasi begini, di mana patient akan diteliti tentang polypharmacy, especially patient who are having a lot of drugs and elderly patient, and the method is patient, the pharmacists are leading, the one that look at or review the medication history at the admission. This is very important. At admission, you need to do that. If, say for example, other healthcare providers, they might not get a full detail of the information, and identify the discrepancy in almost 45%. This is very big, almost half of the patient are being identified, whether the patient omitted the dose, whether the patient are taking incorrect frequency and so on. So this is very important, and this paper was published by one of my former PhD student, which is Rahmawati, di UGM, dari UGM ya. And if we look at the situation where the community pharmacy collaborate between the hospital and Apotek K24, which is national pharmacy here, they already developed some of the medication history platform which can be utilized at the end of the day. The challenge that for them is to having between the hospital and community pharmacies. Recently, I received a lot of information or asking me through WhatsApp from Papua, because I have a student from in Papua who is working as a pharmacist right now. They are asking a lot of questions regarding whether these particular drugs can be used, because they receive prescription from the doctors, and it seems like just what like I say about the seizure just now, it seems that the patient do not have that situation, or probably patient do not realize that they have that situation because probably the doctors did not inform them they have, say for example, high cholesterol. Okay, but the on the prescription is having simvastatin and so on. So this is very important. So I received a number of questions and also information from our colleague around in Indonesia to see what we can do to help them. Okay, so this is a very big thing, and the challenge is that in most of the hospital, it might be very limited EHR condition in some of the hospital, especially a smaller hospital. Okay, and the key challenge is the workflow barriers. You will see that there is a lack of dedicated nurse staff to do the MREC. The problem is, who is going to do it? You, me, or whom? You know, there is no dedicated person to do things. But in some hospitals they might have, but not every hospital. It could be because of the cultural, because of the patient's factors, and then, of course, as mentioned by two of my colleagues, the technical and also the technology gap that the patient, the situation might be slightly difficult, because most of the thing right now is still in paper-based rather than EHR-based. Okay, and the fourth, the progress and opportunity. You will see that the Ministry of Health promote e-prescribing and digital health record, Satu Sihat platform ya, kalau dikatakan. So this is something that support the MRED definitely. Okay, the only problem is that how far, how good have you done this? So that need to be relooked and also see what are those local situations that you need to adapt in terms of getting it much better. Okay, and leading hospital like Cipto are piloting some of the MREC as a part of accreditation requirement. This is very important, because at the end of the day, if your hospital is need to be accredited by world global condition, you need to have the record with the MRECs and so on. Okay, this is a comparison that's been done in the Asian, that was published by the ASEAN countries, and it shows that in Malaysia we are slightly better. We are in the advanced phase in terms of MREC, where those are mandated by the Ministry of Health. Thailand in a moderate condition, where they are also doing with the smart pharmacists, and come with Philippines and Indonesia, where you started to emerge all those situations for MREC. Okay, and in Malaysia, it is noted that 92% of hospitals have pharmacists who are doing or dealing with MREC. Okay, so we have a specific person doing it. Probably one of the reasons is that we have huge number of pharmacists in one hospital. You know, like in Penang, we have about almost to 300 apoteker di dalam satu hospital yang bednya sekitar dalam 1000-an gitu, ya, 200-300an apoteker di satu hospital karena kita banyak specialization yang dilakukan. So in Thailand it's only 68 in urban and 41 in rural. In Indonesia, based on this ASEAN consortium pharmacists, it looks like that 18%. But I think because this data is in 2022, probably by now you have gone much better in a way. And these are the common obstacles in MREC. Number one is the incomplete data. Why? Patient forget to informed by Dr. Yunita tadi, forget to tell you about the OTC products, about some of the new the herbs that have been taken. The structured interview usually use open-ended question. What do you take for pain instead of do you take pain meds? It makes different. Apa yang ibu ambil untuk kalau ibu mengalami kesakitan dengan adakah ibu mengambil sebarang ubat untuk kesakitan? It make two different things. Okay, then the patient might say yes I am or no I don't. You have a very short, but apakah jenis obat? Mungkin kalau beliau tidak mengambil, saya tidak mengalami sebarang kesakitan, maka saya enggak mengambil sebarang ubat untuk mengatasinya. Atau patient may say, oh I chew this herb, it causes lesser pain, and you want to know more about that herb. What is it? And it turned out to be certain herbs that have potential interaction with other condition or other medication that the patient may have. You need to get the partner to fill all the history, especially from community pharmacy. So this is where it is very important for hospital-based, academic-based, and community pharmacy-based to get in touch together. By having all the information together, you will at least to get a complete the medication review for the patient in terms of dealing with the situation. In Malaysia, we have My Farm Care Network. Okay, we have some of the community pharmacy that link together to get the information, because the patient might giving the information at that community pharmacy and then at this hospital and so on. Okay, usually the other things that we make and what we can do about it is the silo healthcare system. Why it happen? Usually di Bali akan buat caranya di Bali, di Jakarta akan buat caranya Jakarta, ya, sehingga dipanggil semua duduk di satu meja. This is what we can do. Okay, tapi pulangnya nanti silo lagi kerana uangnya enggak ada dan sebagainya. So you need to realize that having this problem will not solve some of the things. So siloed healthcare system, kerana kita tidak mempunyai, some of the hospital might not have the electronic condition, hand off between the team, the patient, contohnya patient dari emergency department masuk ke ICU misalnya, there is no communication between the personnel in emergency department to the ICU department except the information that being written by physician for that particular case. And the solution is that kebiasaannya untuk mengatasi masalah ini, we need to have a pharmacist that can be the first liner for the med-red in that situation. Okay, we can reduce in some of the journals said it may reduce up to 82% of the admission and also discharge errors for that particular situation. And standardized tool, kita menggunakan VRO, med-rec situation, di mana kita menggunakan checklist ini ataupun beberapa checklist yang lain, dan contoh yang bisa diberikan adalah Thailand AI powered med-rec that scan the paper script into the EHR. Jadi kalian tidak perlu lagi, kita jadi tidak perlu lagi untuk apa? menggunakan elektronik ataupun tulis, ya. Okay. Time constraint, yeah. Why it happened? Because it takes a lot of time to do it. You know, you need to write on a piece of paper, and you're going to see that terlalu memerlukan waktu. Thank you very much. My throat is dry. Thank you. So kita akan melihat bahawa terlalu banyak, ya, yang the time constraint di situ. It happened that clinicians spend less than 5 minutes on MRAC, busy with the shift usually, and the focus is that to prioritize the high-risk patient as mentioned by Dr. Yunita tadi, and at least kepada mereka yang mempunyai banyak sekali medication, more than 10 medication, and also for those who are using the anticoagulant, yeah. Pre-visit, have the patient complete medication history in that sense. And mungkin kerana gap of literacy is there, usually solutionnya adalah menggunakan we teach back, ya. Waktu saya di Afrika kemarin, ini ketika saya di Afrika, kita menjalankan situasi untuk melihat apakah pasien-pasien di Afrika itu, di daerah yang saya pergi ini, mereka benar-benar mengetahui tentang obat apa yang mereka ambil dan sebagainya. Dan kita seharian di situ bersama dengan pasien, ternyata ramai daripada mereka kurang mengerti tentang obat yang diambil, kurang memahami bahawa kalau diambilnya 2 kali sehari itu, bisa diambil 1 jam pagi, kemudian tengah harinya diambil lagi. It's not 12 hours kind of thing and so on. So this is where we need to teach back method, and we need to have a color-coded medicine. Contohnya kalau di pagi itu warnanya, kodnya warna kuning. Ini dah ambilnya di waktu pagi, ya. Yang ini diminumnya waktu malam, contohnya. So that is what we did in Africa last time. We teach them how to remember things easily, because most of them in the rural area, they might not have the facility to have a good education based on the medication condition. Lack of accountability, there is no clear ownership. Okay, siapa yang mahu melakukan ini? Pak Doktor, pharmacists, nurses, or who is going to do that? So you need to be clear. Usually you need to assign somebody to do it, especially in this area is a pharmacist need to do it, and then you need to have an audit, feedback, review again. What happened in that situation? Example, John Hopkins reduced errors by 60% with audit. So you need to review audit and see where is the mistake, what happened. Oh, we do not have a specific person dealing with MedRec. So our errors shooting up from 20% to 55%, say for example. So you have to find somebody to do the job, you know. So looking at that, monthly errors report is very, very important so that we know where we stand at that point. Okay, and this is our stories in Malaysia. MedRec reduced in 2 years, consecutive years, minimum of 40%. And in Thailand, they are using the AI at this particular hospital, Sri Raj Hospital. They cut down the time from 30 minutes to 8 minutes for MRAC per patient, which is very good. Okay, and summary for the obstacles, we will see that missing herbal max is one of those. Kita sudah berbincang tentang soal itu. Solutionnya seperti yang dilakukan di hospital di Indonesia, Sajito, you use brown bag reviews to review some of the medication. EHR fragmentation, ada yang buat, ada yang enggak ada. Jadi perlu melihat sebagai pharmacist as they backup for MRAC, quarterback, This is bagaimana yang berlaku di Malaysia. And this is example component of the MREC yang kita lakukan di Malaysia. Kita ada core principle guideline di mana pharmacist ataupun apoteker itu adalah orang yang terkehadapan dalam melakukan MREC. Rationalnya adalah pharmacist dapat detect 94% daripada medication discrepancy versus 48% by physician. Ini adalah data-data yang kita dapat. Ya. Physician dapat detect about 50%, almost 50% of that particular problem, but pharmacists detect more than 90% of the problem at that point. The standardized workflow, kita punya protokol yang tertentu untuk MedRec ini. So when you have a protocol, the standardized workflow is going to be there, and we focus on the high-risk patient and so on. The second one is that the tool that we use. We need to use a standardized tool because at the end of the day, if this hospital is using different tools, you will see that it's difficult to synchronize. What information you have might not be what the other might have. So we have a standard tools for this where we look at the home medication, the hospital orders, discrepancy, example the use in GHKL in the emergency department, reducing about 40% in 1 year errors. Okay, and digital integration, whether we like it or we don't like it, the technology is there. We have to use the technology to come up with it. And know your max, ya, kenali obat anda kalau di Malaysia itu is one of the education that teach the patient how to know their medication very well. And success, looking at the KPIs, the MedRec completion within 24 hours. So there's a lot of increase in the improvement of the completion within 24 hours. Admission, resolve discrepancies, and at the end of the day, we saw that it 35% lower in ADE alone. If you are looking at the ADE alone, and this is published in BMJ Malaysia last 2 years. And comparison for the improvement, kalau di sini, kalau di Indonesia itu seharusnya apoteker perlu memainkan peranan penting, ya. Saya menyarankan supaya kalian nanti selesai ataupun dosen-dosen yang ada di sini yang praktik, kalian ambillah peran itu sebagai sesuatu yang bisa menonjak ke arah yang lebih bagus. InsyaAllah with your role, skills, knowledge, you'll be at par with the rest of the part of the world. Cuma sekarang ini mungkin leadershipnya lebih kepada perawat dan juga physician based, and you have the tools kebanyakannya masih lagi dalam paper based, and patient role is passive, meaning not many will get the the education for the patient, but make it move. Saya sarankan nanti kalau di Indonesia itu MTech jika diadakan itu sangat senang kerana kita incorporate MREC dengan education dan sebagainya di dalam satu klinik tersebut, dan klinik tersebut adalah yang tonggaknya adalah apoteker. Ya. Dan bila melihat begini, you can really make it done. It can happen. It can happen. Itu yang terjadi pada kita dahulu. I mean, we were not having all this, but we do it slowly. Start with a very small situation where you can improve, and kita melihatkan bahawa kita sudah membuktikan bahawa perubahan dengan sistem itu bukan hanya pada teknologi, tetapi apabila kita melakukannya, sebenarnya adalah apa yang kita lakukan untuk meneliti situasi tersebut. So here are some of the practical things. Start small, adapt background days seperti di Indonesia yang telah lakukan. discharge hurdles, mana-mana obstacles yang ada itu harus diteliti. Strengthen the strength of the system that you have. Give yourself about 6 months to a year to see it. Gunakan low tech first. You know, you don't have to have a very big technology. Start with a very small one. You know, go from there and empower the patient tools to improve, seperti launch a kartu obat saya, my medication card, and training the community about the medication. Kemudian scale up and deal with the curriculum. Untuk dosen-dosen di universitas, kurikulum itu harus sejajar dengan kefahaman global sekarang. It cannot be outdated, otherwise you are producing a student who is going to be practicing with a lack of some of the skill that you might have. And of course, private sector partners is very, very important. Overcome the cultural, measure the improvement. You have to have a audit for this, and a call for action that's been done. Train one pharmacist. Train somebody at one hospital or one setting or one community pharmacy to do this job, and you will go from there. So this will look at to add into what the accreditation need to do for that particular things. I will just go directly to the closing the loop here. So, paint the urgency. Lihatlah bagaimana kita bisa membantu pasien-pasien kita, dalam arti kata having a better medrec. Spotlight the opportunity. Kolaborasilah dengan yang mana-mana negara yang bisa dirasakan bisa memberikan manfaat kepada kita. Call ownership, policy, pharmacist has to be there to contribute the information for the policy and end up with a challenge so that you will be the champion in MRAG. Okay? Saya tutupkan dengan ini bahawa kalian bukanlah satu titisan daripada air di lautan. Kalian merupakan keseluruhan lautan dalam satu titisan air laut tersebut. What does it mean? We are a lot. There will be somebody need to be looking at the medrec misalnya. So be that one drop of water of the from the sea. It's not the sea. Kita tidak perlu menunggu uang datang jatuh dari langit. All the apparatus need to be there, only then you can start. No, you just do it, start slow, and then go from there. With that, thank you very much, and I do hope kita semua berubah ke satu arah yang lebih tinggi, kerana apabila orang sudah mencapai ke satu tahap, mereka akan berlari ke gunung yang lebih tinggi, tapi sayangnya kita masih di kaki bukit. Dan kita tidak capai apa yang kita perlu capaikan. Start small, go small, your dreams will be very big. With that, thank you very much dan terima kasih.
Okay, thank you very much, Prof. Syed, for your insightful presentations. So feel free to take a seat. So now we will proceed to question and answer session. So any question? Maybe we will begin to the offline participant. So you can state your name and then your institution, or yeah, after that you can proceed your question. So any question?
Kalian bisa nanya dalam bahasa Indonesia, saya coba jawab.
Yeah, if
you don't have to speak
answer,
in English.
Yeah, if you answer or doubt with your English, you can ask it with bahasa. Is it okay, Prof?
Yeah.
Ya, silahkan kalau ada yang mau bertanya terkait rekonsiliasi.
mungkin kalian sudah tepu dengan informasi yang diberikan pagi ini ya. Sudah penuh informasinya.
Atau mungkin dari dosen, mungkin from clinical pharmacy lecturer, maybe if you wanna asking a question, feel free to ask. Or maybe from the online participant. So let me check it. Okay, this is from Apoteker Gede Ngurah Hadi Chandra. So, good afternoon. I'm Ngurah Hadi. I would like ask question to Prof. Shed. The first one, I'm a bit curious about the complexity of medical reconciliation that include many aspects and people in it. And then what is really core of medication reconciliation so we can do some basic before doing some more advanced further. And the second question, how can we encourage ourselves as pharmacists to take role in patient, especially in medical reconciliation, and further we will be considered in patient care? Thank you.
Okay. The very basic thing is very simple. Medication, patient medication history. That's the basic thing. Okay. It started with that. Because all the patients that came in, all the patients being discharged, you will need to get the information there. Okay, itu yang sering, itu kan kita sering lakukan. Kalau di sama ada yang datang ke apotek ataupun memang keluar dari hospital, discharge dari hospital kan, seharusnya kita bertanyakan tentang ubat-ubatan tersebut. That is a very basic thing. Tetapi setelah itu mungkin kita boleh translatekan information itu ke dalam bentuk teknologinya supaya dikumpulkan data-data itu untuk kita perhatikan apakah data ini menunjukkan setelah melakukan medication reconciliation ini memberikan manfaat kepada outcome of the patient. So that is what important. So the basic thing is that the skill of communication, your knowledge regarding the medication that the patient is taking, and the communication that you need to look at, whether it's based on the barriers like the patient might be hearing problems, cultural, and so on. So harus kita mendapatkan skill-skill communication itu untuk mendapatkan informasi yang bagus agar kita bisa membantu mereka untuk menghalang daripada berlakunya ADE ataupun polypharmacy ataupun apa saja yang berkaitan yang boleh memudaratkan pasien dalam situasi tersebut.
Okay, thank you, Prof. So the key of the answer is communication, right?
Yeah, it's very important. It seems like kalian di Gen Z itu komunikasinya sama gadget, okay? Jadi you need to rephrase again that situation so that kita sama-sama melakukan situasi tersebut. Mungkin di generasi saya tidak begitu, you know. We speak different language. We prefer face to face, but mungkin generasi sekarang beda. Jadi kita cuba masukkan, dorongkan situasi tersebut untuk membantu semua generasi. Especially when Dr. Wong said there's a lot of cases with the young diabetic. How are you going to communicate? You know, they might not want to communicate to you face to face, for example. Then we have all the technology to help them to deal with the situation. One thing that is important, kalau saya di klinik saya itu, saya sering, the first thing that I'm telling them is that apa yang kita lakukan hari ini bukan untuk saya. What we are doing today is for you. You need to do it for yourself. You cannot depend on doctors, you cannot depend on pharmacists, you cannot depend on perawat dan sebagainya. You know you have cardiovascular event. You need to know the medication very well. Nobody else will. Your son cannot do it unless, you are not that good thing of memorizing something, then the spouse or your son or your daughter can do the job. But otherwise, it's yourself that responsible to do it. And perkara ini saya tekankan supaya semua pesakit saya waktu itu memahami bahawa konsep menjaga diri adalah ataupun konsep mendapatkan a good health care sebagaimana yang diterangkan tadi is your own responsibility. Kita hanya membantu. Kita tidak bisa pergi ke rumah 3 jam menunggu mau makan obatnya apa, dengan siapa kamu makan begitu. Tidak. So they have to be honest with themselves. So this is where the basic thing is. You get this skill, how to communicate, use the technology to help to improve, and based on all, the empathy is very important. You need to know what are the barriers. They might not want to be talking about it because they are shy about it, say for example. So overcome the problem by discussing thoroughly what might be the problem that you or the patient might having at that point.
Okay, thank you, Prof. That is a great answer from you. So, if I may connect with the prospective pharmacists here, the Gen Z, because they're like in transition from the digital communication, so they usually communicating digitally and then start to begin like face-to-face communication. That is very important.
Yeah.
Because nowadays, the Gen Z or maybe most of us, like they are actively communicating digitally, like texting message, and then but in face-to-face they were like, just silent.
So this is where we need to improve the hurdles, the obstacles. They might not have that skill by the other gen have, but we might not have the skill that they have. They are very innovative in technology and so on. Saya masih ingat lagi waktu beberapa tahun yang lalu kita lakukan WhatsApp for patient who is pregnant, looking at the diabetic condition in pregnant women, and we use WhatsApp. Kerana ramai itu adalah ibu-ibu yang muda, they might not having this. So we are using video, sending through WhatsApp, and then we get the information regarding their medication and so on. And we already published that paper to look at the improvement in terms of sugar, level of sugar in patients who are having diabetic during pregnancy and so on.
Okay, thank you, Prof. So, any other question? Okay, maybe there's another one. Okay, this is from Ayu Surya. Okay, dear Prof, I'm interested with your journey to many countries in your presentation. I'm curious to know, did you do any assessment in every country about their pharmacy practice, in community pharmacy especially? Then which country have the best practice in community pharmacy according your journey to every country? Thank you.
Okay, all right. To me, there is no one country that is the best. It's very much localized to your own country, That was what I did in ACCP, that telling you that you need to grab the information from other country, but you need to adapt locally. There is no point you get information from UK, from Malaysia, from Singapore, and then suddenly you cannot do it at your country. different countries have a different approach, different ways of dealing with this situation. We cannot put one shoes for everyone. It has to be different. So kalau pada saya itu tidak ada yang terbaik, tetapi mungkin ada di negara ini ruangan ini yang terbaik. Bisa kita adapt untuk kita improve. Dan di negara itu mungkin ini yang kita perlu telitikan karena di negara dia itu melihatkan teknologinya kayak gini. So those are the thing that can be done. Sepanjang saya dalam journey to improve the education and also all these thing, to me different country have a different good asset on their own. Ya, kalau di Indonesia ini kan apotekernya ramai. Apoteknya banyak sekali. So one of the things which is your asset is get together and you can do it. But if you are doing in silo, it's different issue. Kalau di Malaysia itu mungkin 1/4 daripada jumlah rata-rata farmasis di Indonesia, enggak ramai seperti di Indonesia ya. So you have done the thing accordingly. So this is where pada saya there is no one country which is really outstanding. They might be very outstanding this, but we look at this aspect, we are much better. Contoh, ya. So it's different. That is my personal opinion. You might see it differently. Kepada saya, even contohnya saya ke Mongolia, ya, mereka ada sesuatu yang kita juga tidak tahu. I learned from them. I went there to inform. WHO asked me to revamp the syllabus to add in clinical pharmacy for pharmacy degree, and I was asked by WHO to persuade doctors not to use injectable drugs anymore for all the drugs, because kalau di Mongolia itu semua obat termasuk paracetamol digunakan secara injectable. Okay, which causing a number of hepatitis and whatnot, infection karena penggunaan itu. Dan mereka mulai berubah, So different thing in a different country lead you to ideas of what to do for your own countries. Kayaknya saya begitu, ya, supaya diambil dari negeri orang, tetapi coba digunakan di negeri kita, gimana ianya bisa cocok dengan local situation, cultural kita dan sebagainya. Karena tidak mungkin kita mengambil 100% daripada mereka untuk kita lakukan di kita, karena resources kita mungkin terhad, keuangan kita mungkin terhad, mereka punya dana yang tinggi, kita tidak. Jadi mereka bisa mendapatkan teknologi yang bagus, kita kurang. Jadi it doesn't mean that you cannot do it. Say for example Bangladesh, mereka tidak perlu mendapatkan teknologi yang tinggi, dia mendapatkan low band untuk rural area digunakan sedemikian. So these are the things yang kita bisa lakukan. Adapt the knowledge, skill from different country, but put the best for your own country. InsyaAllah saya yakin Indonesia will be very good, excellent one day. InsyaAllah. You are already there. InsyaAllah.
Okay. Yeah, that is a great answer from Prof. Syed. So, just be confident. There is no best pharmacy practice on one country, right?
It's not no best. It's just that everybody have doing their best.
Yes.
But to me, different country has the best of different things.
But different character, yeah. Okay. Wow, there's many questions. This one question is from Maderian Putra Gunawan. Okay. The question is with bahasa. Selamat siang dokter, perkenalkan saya Rian. Menarik sekali materi yang sudah dibawakan oleh Prof. Syed mengenai rekonsiliasi. Mengenai rekonsiliasi memang banyak tantangan di lapangan, terutama di rumah sakit. Contohnya ada beberapa pasien lansia, traveler yang membawa obat, tapi tidak mengetahui mengenai obat yang digunakan. Jadi the patient didn't know how to use this medicine, and then sehingga kadang kami merasa kesulitan untuk melakukan rekonsiliasi. So the pharmacist like cannot doing the reconciliation properly, and then menurut Robset, bagaimana cara memaksimalkan rekonsiliasi pada pasien baru? So how to maximize the medication reconciliation to a new patient, especially geriatry.
Okay.
Yeah. If they didn't know how to use their medication.
Okay. Alright, terima kasih. This is what saya bilang tadi ya, education. Education is very important. Once the patient is being given the medications, prescripsi obat itu, all the frontliners, kalau di apotek itu, apoteker itu seharusnya membimbing. Bukan sekadar, ya Bu, ini obatnya minumnya 2 kali 1 hari, ini waktu pagi, ini waktu petang, terima kasih, datang lagi. No. You have to tell the patient, like what saya lakukan di klinik saya itu, mereka semua illiterate in term of medication. Kali pertama saya buka klinik itu saya juga capek, lelah. Karena hampir keseluruhannya enggak tahu, oh obat saya minum itu warna putih, mungkin untuk ini, mungkin untuk itu, enggak tahu mereka. Tapi kita panggil, kita terangkan. Konsep saya adalah untuk mereka belajar. Apa yang saya lakukan kan, saya akan tulis nama obat itu, masukkan ke poket mereka, simpan ini Mbak. Setiap kali lupa, lihat, baca. Within 3 months, they can know what their medication is. Itu namanya education. Tapi jangan lakukan education yang menyusahkan mereka. Oh Mbak, ini obatnya ini namanya metformin gini. Mereka enggak ngerti menyebut. Ini insulin. Setahu mereka insulin itu insulin lah. Kita bagi long term insulin ke short term insulin ke. Pada mereka is insulin. But when you come with the patient, you say, okay, ini adalah insulin yang tindakannya pendek. Namanya begini. Yang obat yang diambil ini namanya metformin. Itu karena saya katakan tadi, setelah 1 tahun, 98% hanya seorang saja sebenarnya tidak lulus hemoglobin A1C itu. 98% dari pasien saya itu bergraduasi, wisudanya pada Hari Diabetik Sedunia. Mereka duduk bersama Presiden Persatuan Endokrinologis Malaysia. Bapak itu bertanya dengan salah seorang daripada pasien saya yang bergraduasi. Dia adalah tukang sapu di ruangan ya, di ruangan school. Oh dia bilang, oh saya sudah mengambil metformin ini sudah beberapa tahun. Dia bilang metformin, saya mengambil insulinnya berapa unit dan kadang-kadang saya mengalami smoke effect. Itu Bapak Presiden kaget karena mereka mengetahui soal-soal itu, bagaimana melihat kepada hyper, apa interaksi obat ini dengan obat itu. Kita malah di klinik saya itu kita ada 10 minggu untuk education. Kita memberikan setiap 2 minggu dan diulang lagi supaya mereka ingat. So at the end of the day, in 1 year, everybody remembers what they are taking. Jadi ini memberikan cara kita mengedukatekan mereka itu harusnya jangan sampai nyusahkan mereka untuk ingat untuk apa. Jadi setiap kali sampai mereka kali pertamanya enggak tahu itu hemoglobin A1C itu apa. Jadi kita terangkan pada mereka ini begini. Sehingga kan satu saat bila mereka dapatkan keputusan tidak dapat ke mereka, dapat ke saya. Dan saya akan kata ada 3 orang yang gagal pada kali ini. 4 orang yang di dalam julatnya dan 1 orang di atas pagarnya. They know who they are. because they knew that whether they are taking medicine or they are not doing exercise or what. Jadi kita harus mengajar dengan pembelajaran yang cocok dengan mereka, bukan yang apa yang kita inginkan. You know, you have to remember you are here, but you have to put yourself there together with them. Kalau kita di tempat dia gimana? Mau kita belajar apa itu metformin semua, enggak tahu kita. So untuk soalan itu pada saya, education is very important. Before you start a lot of things, you have to educate. You know, kita mau melakukan med-red itu bukan sesuatu yang senang. You know, melelahkan kita kerana banyak informasi enggak ada. Tapi setelah kita melakukan edukasi, insya-Allah semuanya bisa dilakukan dengan tertib, insya-Allah. Mudah-mudahan.
Okay, thank you, Professor. So, wow, there is any other question from the online participant? This one is from Prabha Kezia. So, good afternoon. I'm Kezia Manachika. Professor, I want to ask something which is very common I found in pharmacy practice. When we ask the patient what medicine they took, they said, I forgot. So, as a pharmacist who wants to get a medical information from patient, what should we do? Beside, maybe we search the database before. Thank you.
Okay. Back to square one, the same thing, education. Okay. Kalau di saya, kalau yang tidak ingat itu, kebiasaannya for the next trip, kerana kan kita ada rekod pasien itu. Jadi kalau mana-mana apotek ataupun hospital yang tidak mempunyai rekod agak sukar kalau kali pertama kita ketemu, ya, dan mereka tidak tahu. The best thing is that if that patient bring you the prescription, you may call the doctors to see what are the other medication that the patient may have. Tapi sekiranya patient itu datang untuk mengisi ubat, refill the prescription, dia pergi ke apotek yang lain misalnya, ya, di daerah lain mengisi yang pertama. Sekarang dia tinggal bersama anaknya di sini, mengisinya di apotek ini. Jadi informasi itu enggak ada. Jadi the best thing is that to get somebody who knows her situation. Anaknya mungkin, kalau saya minta beliau membawa semua obat yang ada di rumah itu, kalau dia bisa datang. Then you can see, because we cannot guess. Kalau dia kata, saya mengalami hipertensi, saya mengalami ini, obat hipertensi saja udah macam-macam. How do you know is losartan or amlodipine or whatever? You know, obat diabetik juga macam-macam. Ada suntikan saya tak tahu, ada disuntik atau tidak. Itu that's a little bit difficult. So the best thing is that get together, probably ask the patient what's the problem of having this kind of thing, dan cuba dihubungi orang yang yang terdekat dengannya, whether it's medical doctors, which we can get all the information in a better way. Dokternya mana? Saya pergi ke hospital ini, nama dokternya ABC. Jadi kalau ada ruang, ada waktu, nelpon dokter tu, bertanyakan, ini ada pasiennya namanya sekian-sekian, lupa nama obatnya apa, saya di sini mau refill the medication, and you go from there asking, and from that very own moment educate the patient. Berikan satu persatu. Obat yang paling lama dimakan ini obat yang baru. Focus on the obat yang baru, kemudian pergi kepada obat yang lama, so that the patient need to know what are they taking. Kerana kita akan capek kalau tidak punya informasi itu. Jadi kita jadi ya udah enggak tahulah. Enggak boleh, kita don't give up. There's a lot of ways that we can help the patient to improve their way of getting to know their medication and so on. Inshallah boleh.
Okay, thank you, Professor. So the solution is like we can ask the closest person, and then from the doctor who gave the prescription, and then if we can can get data from those, so we can ask the patients to bring all of the medication to us.
Yes.
Okay. Okay, thank you, Prof. Sheikh. So, wow, the time is out. Okay, yeah, sadly the time is out because I actually have one question, but this is personal to me. So, can I get a minute? Yeah. So, we know at the hospital there are so many health profession there, and we have to respect each other. And then, but in practice, like pharmacists are often seen as like we looking for their mistake, especially on like we have often seen like of interfering them with drug therapy, particularly in drug selection. So what can pharmacists do to ensure this is indeed the pharmacist's job? So,
okay.
Yeah.
Let me rephrase the question.
Yeah.
If I'm correct with what I'm hearing you.
Jadi kita sering dilihat seperti mencari kesalahan dari profesi lain dalam memberikan terapi.
Okay.
Nah, bagaimana?
Betul.
Kira-kira.
Itu yang saya katakan, you need to calibrate, but not to be seeking for mistakes by others. You know, kita adalah menyumbangkan ke arah yang lebih baik. Okay. Kalau saya masih ingat waktu saya mula-mula pulang dari belajar, saya memulakan ward rotation untuk pharmacokinetic, dan Pak Doktor tidak senang dengan kehadiran kita waktu itu. The doctors are not really welcome us. Saya bersama seorang lagi teman, dan saya katakan bahawa saya ingin belajar. So be with them. So when you have a case, you show your role, that you are actually can contribute in the discussion. You show the role that a pharmacist itu bukan hanya mencari kesilapan, tapi adalah untuk memperbaiki dan meningkatkan mutu perkhidmatan. So when you do that, people will realize that you actually have the skill, you actually have the knowledge, you actually can collaborate with them to improve the healthcare outcome. Kerana mereka merasakan bahawa ya udah, aku ini pasiennya sudah ramai, kamu datang lagi di sini kayaknya seperti mengganggu gitu. Jadi kita contribute accordingly. Kalau kita bersama di dalam situasi begitu tidak contributing anything, semangnya mengganggu itu. So you need to give your knowledge, your skill of communication, and what is beneficial for them. Dan kita bukan mencari salah. Dulu saya dipanggil walking martindale. Saya dipanggil sebagai walking martindale kerana setiap kali berbicara kalau doktor itu tidak bersama dengan ide-ide kita, saya akan print a copy of articles or few copies of article dan saya letakkan di mejanya. Saya cuma bicara, Doktor A, tadi saya ada letakkan ada 2 artikel, mungkin you would like to have a look at it. You know, kita tadi beri saran bahawa harusnya nukar gini, tapi dia tidak bersetuju. Jadi besok kita lihat bahawa the dose has been changed accordingly. So you do not have to find the mistakes of others, but you improve mistake of others. And dari situ mereka panggil, itu walking martindale-nya, ada tanya dia. So this is where the pharmacists contribute in the way. Kita kalau masuk ke rumah orang itu seharusnya rasa rendah diri dulu, ya, jangan mengacau situasi di rumah orang gitu. Kita belajar, and we go from there. Your PR has to be very strong. Itu communication skill. So mudah-mudahan begitu. Ya, kita artinya don't find somebody's fault. Kita juga faults kita juga sudah banyak. Jadi don't find somebody else's fault, tetapi belajar dengan mereka dan memperbetulkan diri kita sendiri dan memberikan pandangan apakah yang bisa kita lakukan untuk kebaikan pasien ini. Mungkin pandangan kita tidak diterima, tapi apa yang saya lakukan seringnya, I give the papers, bukti yang mengatakan bahawa seharusnya kayaknya begini. So they appreciate, kerana mereka tidak punya waktu untuk cari-cari semua ini. So we did, and they accept. So after that, they don't have to get the papers anymore. Just call that particular Martindale. I want to talk to him. That's all. Yeah.
Okay. Thank you, Prof. So this is a very great discussion we have here. But we have reached the end of our allotted time. So I would like to express our profound gratitude to our esteemed speaker here for the enlightening, and to all participants, thank you very much for your active engagement. So the insight that shared today have deepened our understanding about how important the role of pharmacists in medication reconciliation, what is the obstacle, and how we deal about the obstacle that exists in carrying out this practice. So before we end this session, maybe Prof. Shed have closing remarks, maybe.
Okay, as I've mentioned earlier, kita adalah peneraju kepada pemulihan clinical outcome untuk pasien kita. Jadi berusaha ke arah itu, improve ourselves and gunakan teknologi untuk membangun dan juga menyelesaikan apa-apa juga masalah yang kita mungkin lakukan. We are the best, insyaAllah.
Okay. So it's time to me to end this session, and I apologize if I have mistaken to saying words, and allow me to end this session with Paramasanti, Om Santi 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 Om. Assalamualaikum warahmatullahi wabarakatuh. Sadu, sadu, sadu. Salam kebajikan untuk kita semua. Terima kasih. Thank you very much.
Hey, very interesting discussion, right? And thank you for Professor Syed for your very thought-provoking presentation. And maybe I can take one key point from Professor Syed's presentation, that we have to always educate patient. Keep educating patient, because that is a very essential thing before we start everything in our practice pharmacies. And I would also like to thank to our moderator today, Mr. Budiarta Syada, for leading this session with clarity and expertise. We will now proceed with the presentation of certificate as a token of our appreciation. May we kindly invite the Dean to the stage to present the certificate. and gentlemen, as we come to the conclusion of this international seminar, allow me to express our heartfelt gratitude to all speakers, moderators, and participants for your valuable contribution and active engagement. May the insights shared today inspire ongoing collaboration and meaningful improvement in pharmacy practice for the benefit of patients everywhere. Finally, we close the seminar by saying Om Santi 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 Om. Wassalamualaikum warahmatullahi wabarakatuh. Shalom, sadu, sadu, sadu. Salam kebajikan. Thank you and have a good day.